Murray. I'm the Joint Chair of the Health and Wellbeing Board. I'd just like to reassure everyone, this is the first time I've done this, so just to reassure everybody, I'm a much better GP than I am a chair, so if any patients are watching. So I'd just like to welcome everyone. Thanks for attending the Health and Wellbeing Board. The meeting today is open to the public and it's being webcast. We've received no public questions. The agenda reports for today's meeting are available on the Council's website, and a small amount of paper copies are available if anyone needs them. And please can I request that mobile telephones and other equipment are switched off on silent mode to make sure that we don't disturb the conduct of the meeting. There are no fire tests planned. If there is an emergency evacuation, please take instructions from the Town Hall staff, and the assembly point is Tudor Square. Before I ask board members to introduce themselves, a quick update on recruitment of new board members following last year's review. So just to welcome all the new members, those who are here and those who can't attend today. So the nominated clinical representative of Primary Care Networks is Dr. Lee Salisbury. Put your hand up, Lee. Okay. The nominated representative of partners working with or for children and young people is Yvonne Millard, Chief Nurse of Sheffield Children's Hospital Foundation Trust. Welcome. The nominated representative of partners working to support mental health and wellbeing is Rachel Civiter, Chair of the Sheffield Mental Health VCSE Alliance. The representative from the VCF organisation working with a locality is Megan Orry, Partnership Manager of SOAR. May Connolly, Community Team Manager at Healy Development Trust, will deputise. And then the nominated representative of NHS Acute Provider Trust, and for representative from a VCF organisation working with a specific group, recruitment to these places is still ongoing. And Yvonne and Megan will be joining us for the meeting today, so should formally welcome them. Guess I wasn't supposed to read that bit, I wasn't. So Rachel, unable to attend, and ask each board member in turn to introduce themselves. So let's start with that. Shall we start with Kate?
Afternoon, everybody. I'm Kate Josephs, Chief Executive, Sheffield City Council.
Greg Fell, Director of Public Health.
Hi, Sandy Buchan, Director of Strategy for Sheffield from the South Yorkshire ICB.
Catherine Robertshaw, I'm the Interim Director for the Sheffield Health and Care Partnership.
I'm Lee Salisbury, who can't work microphones. I'm a GP in Sheffield and representing PCNs.
Hi, I'm Joe Rennie. I'm Group Director for Student Academic Services at Sheffield Hallam.
Hi, my name is Ben Kemp. I'm Superintendent for Neighbourhoods and Partnerships at Sheffield District, and I'm representing South Yorkshire Police.
Hello, I'm Judy Robinson. I'm the Chair of Sheffield Healthwatch, which is the watchdog for health and social care for patients and communities.
I am Helen Steers from Voluntary Action Sheffield.
Hello, Janet Kerr. I'm an Assistant Director in Adult Care and Wellbeing. I'm deputising for Alexis Chapel.
Hi, I'm Megan Orey. I'm the Partnership Manager at SOAR Community.
Hello, my name is Yvonne Millard and I'm the Chief Nurse at Sheffield Children's.
I'm Douglas Johnson. I'm a councillor and I chair the Housing Committee of the Council.
And I'm Councillor Angela Ardens, who I'm the co-chair of this board.
Okay, brilliant. Thank you, everyone. Apologies for absence. We've got Dr. David Black, Alexis Chapel, Councillor Don Dale, Shelley Hemsley, Dr. Mike Hunter, Andrew Jones, Kate Martin, Rob Sykes, Rachel Silverter, and Emma Latimer. Have we got any other apologies? No, that's brilliant. So then let's move on to declarations of interest. Anyone got any declaration of interest that they wish to make? And we have no questions from members of the public. So should we move on to the first agenda item, which is the Healthwatch update, and that's Jessica. Oh, it's Judy. Why does it says Jessica? So.
Okay, thanks, Chair. Just for new members, Healthwatch does a update at this meeting of things we're finding, things that people are telling us. And it's a canary in the coal mine, the things that are really pushing up the agenda that we're hearing about. over the last 3 months, we've had about 300 pieces of feedback from patients and communities, as well as pieces of particular projects where we've been talking to people. And I'm going to draw on 3 areas to highlight to you today. And the first one is about GPs. And Zach, if you are breathing a downward sigh, the first point is that a lot of the feedback we get is positive. People saying we've had a great quality of care, we've had prompt treatment. It is not all a bad news story by any means. So really hope people take that away. But the second area is this piece of work people may have seen and certainly might have heard on the radio about a survey done of GP websites. And that survey was done by our staff and by our volunteers. And I want to pay tribute to them. They do a really important job. And just pick out a few things from that. If we think the websites and online and virtual is important and will be critical for the health service in the future, we've got to get this right. And there's some things that are not quite going right. And I'll pick out 3 of them. On a number of those websites, it was really hard to navigate. The information was poorly organised. I'm sure everybody's had experience of that on a whole lot of websites, so that it means people get put off. And things like easy read, so the access for people who maybe, whose English maybe isn't their first language, not quite there yet, so some more to be used. And I think our volunteers and others felt that the opportunities to use websites were not being realised. Healthwatch thinks there should be a range of access, but certainly where there is a website, it ought to be done well, and that will help to cut costs, to help people to navigate to the right place quicker. So that was one area. The second one was about access to appointments. We didn't see any website with a text option. And 19 only have a phone number to make an appointment. So for people who are deaf or hard of hearing, there are more and more not having a text option, which is often their favoured way of communicating, is a real issue. It could be fixed so easily and would make a big difference. And then the third one, which is a campaign that's been going on with the NHS, is about how you register. And this is a particular issue about equality of access. So 46 practices mentioned the need to bring ID or proof of address. 16 said it must be provided, but that actually isn't the case. So for refugees, for homeless people, for travellers, that's a real problem, but it's not a requirement. So I think that again, there's a gap there between what the NHS is strongly recommending and what's actually happening on the ground. So we need to close that gap. There are some exemplary websites and practices, and they're in here. Have a look at those as well. But there are some things that I think could be easily done and would make a big difference. So sometimes small changes make a big difference. The second one is about a piece of work we're doing with the Sheffield teaching hospitals, especially the long COVID hub. So it's a piece of work looking at what we suspected, which was that particularly more excluded people are not accessing support when they have long COVID. It's not being identified. They think they are just ill, but actually they've got long COVID. So there's a gap in terms of access to that support. We're doing a particular number of Speak Up grants, which fund small community organisations to look at long COVID in their communities. And they have just gone out, so we'll be reporting back on that. But I think that, again, that link between people and services, how that's done, is really important, and we could probably do more on that. And the third I'll pick up, which links to a number of papers on today's agenda, is about a piece of work done on cost of living, but particularly around health. And what we're finding is that the things that help people to stay healthy, like going to a gym or going to an exercise class, those sorts of things which cost money, are dropping off the agenda. People can't afford to do it. And we did an interesting bit of work with a group called CABS, which is a group for taxi drivers. and they're saying we're working all hours we can do. The cost of taking exercise is problematic, and sometimes there are no local facilities, and they really are often quite unhealthy. So interesting feedback. And I think the other one that we all know about is worry about money has an impact on mental health. And we know that from the work that Citizens Advice do. So there are a number of things there where I think sometimes communication and access would make a big difference. And I hope some of that will feed into some of the thinking and discussion that we have later on the agenda. So thank you.
Thank you, Judy. Any comments? Lee?
Yes, thanks as ever, Judy. Just to pick up on the specific point around people who struggle with hearing and how they access services. We talked about this a lot during COVID, when everything went onto the telephone, or basically online. And I think, Sandy, we discussed this at the time, didn't we? When we canvass, and absolutely there is always more that can be done, and I take your point, and actually we'll take that back to the practices that I'm in contact with. Having multiple points of access is really, really useful for the public. It's really, really difficult to staff at the other end, and that's the problem that we've got. Increasing numbers of staff are no longer choosing to work in general practice. A lot of that is linked to the cost of living and wages and all the rest. When we did talk about it during COVID, a lot of the practices knew their patients who couldn't hear, and it did actually have dedicated text lines that weren't open to everybody because they'd be swamped, but were there for the individuals. That's no good if you're a new patient in there, and obviously we'll take that, but I think often there are local solutions that may be happening underneath the radar, and that's the nature of general practice, isn't it? It's often quite a relational local service, but take the overall point that actually access is really important.
Thanks, Lee. I think Greg was next.
Thanks. 3 quick points. One, thank you for saying the positive stuff about GPs, because it does matter. It's the more we say it, the better, to be honest, because we're all keen to kick GPs when it doesn't go right, but most often it goes. Most often it does go right. I was struck by what you said about the need to provide proof of ID, etc., and there's something that I think we probably ought to do around nailing that one. We want to be a city of sanctuary. We're quite proud of being a city of sanctuary, and if we're systemically putting up barriers, then I think that's probably a reasonably easy to remove barrier. So I think we need to work out what we could do. And then third point on long COVID, it comes up a lot for Sheffield Hockey Health Advisory Service as well. They do a lot around long COVID. I've been running away from it personally for a while, but I think I'm going to have to do a kind of a piece of work working out what we know, what we don't know, what services, both healthcare services and beyond, are available. And I'll suggest that we'll get that scheduled for here and other places, because it's a bit messy and it needs to be organised. I think it could be better. I don't just mean the healthcare bit of it, I mean the totality of it.
If I can just, I think some of that work will be bringing findings forward. It's really just started, and it's also being done with Voluntary Action Sheffield too. So I think there will be some useful information to do that.
Any other questions?
Yeah. Really welcome that, Greg, and I know I've kind of badgered you a bit around long COVID in the past, so I'd welcome, starting to kind of bring some of that together. Judy, I really appreciate your feedback, and I think it's really helpful, and the 3 points, they feel so pertinent to so many of the big challenges that we've got at the moment. I wanted to focus on the insight about physical health and accessing physical health because of cost of living impacts. I mean, we know that is one of the upstream things that people can do to avoid the downstream impacts that we are constantly battling with. We've got a city physical health strategy, and I know that previously I've had conversations with some people here about how that interfaces with the Health and Wellbeing Board. I think it's really important that it's embedded and that it's seen as being part of that kind of long-term set of things we want to do around health inequalities. So I think it's really important that we embed that and we can bring that together, because that's really key insight.
Great, thank you. Just a couple of comments from me. I really welcome the report, Judy. Really keen to do something with it. So we are really trying to spread good practice around practices. It is hell out there at the moment. I mean, it really is. It really is difficult. Somebody said to me the other day, it's really hard to actually have values and put the patient at the centre and work within the NHS at the moment, which I think is a really sad reflection of where we are. The workforce crisis is dire. But I think the difficulty is sometimes when you're under that much pressure, you don't do the simple bits. And basic communication with patients, really important and really simple, and actually doesn't take a lot of time. So what we're really trying to do is help practices, share good practice, and try and just tidy up the websites, because it is important, and actually it saves you time in the long run if you can get it right. I think the comment around the various points of access, it's a really difficult balance. The big fear you get is that you'll get somebody who has got an urgent, potentially life-threatening condition that will contact you through a route that isn't monitored for a period of time. So it is a hard one. But again, I think there's work we can do to try and find ways of navigating that. So I'd be really keen to pick up outside the meeting around how we can try and use some of the information that's there, share it. I'd be really keen to share it across practices. And then that would link into the support that we're giving practices to try and help there. So thank you. Should we move on? Any other questions or comments? Okay, let's move on to Better Care Fund update. And I think that might be Jessica. No? Who's Jessica? Could Jessica put her hand up? Oh, hi Jessica.
Afternoon.
So welcome, Jessica.
I'm Martin Smith. I'm the Deputy Director of Planning and Joint Commissioning, a joint role between the Council and ICB. And I think it would be useful for new members just to say this is about the Better Care Fund, which is a mandated joint plan between health and care. And the agreed plan was signed off by this board in September. We've included in the papers now the assurance that we got back from NHS England to say our plan is compliant, our city plan is compliant with all the national conditions. That was in January, just for audit purposes. And because the plan was only approved in January, it didn't come to the last Health and Wellbeing Board. There was a comprehensive update taken to the Adults Committee that was included in the last paper. So this is probably the first comprehensive Better Care Fund update you've had. It includes up to Q3. So we've got the Q3 data in here, and the purpose of the paper is to provide the board on 4 areas. So the performance against the metrics in the plan, the update on the Section 75 agreement where the pooled funds for the Better Care Fund sit, an update on the governance in terms of the change where the Better Care Fund has been managed previously into where it's been managed now, and the recently published end-of-year template and the timelines for that, and an ask really for a delegated sign-off because of those timelines, but I'll move on to those. And we've included a number of assurance documents, so it is a big paper, and if anyone has any questions about any of that, I'm happy to answer it. So in terms of the key measures, there's 4 measures within the plan. And they are the proportion of older people still at home 91 days after discharge from hospital. We're on track with that. We've got 83%, our plan was 80%. And in the paper we've tried to capture some of the work that's ongoing around this, between health and care, between the hospital and the reablement and enablement teams in the council. There's some really fantastic work. And in terms of the end of year report that will come around June board that will capture the whole year, we can put some case studies in to sort of bring it to life a bit more. We're on track with 3 of the 4 of the indicators, and we're only really slightly missing the 4th, but we're on track with that. In terms of the older adults whose long-term care needs are met by admission to residential or nursing, that's a rate, and we were looking at that rate being lower following COVID. Supporting the home first ethos, supporting people being home and supported at home, and we're on track with that rate. That is also a reflection of the great work that we're doing in terms of reviews, all the social workers out there, everyone's doing a fantastic job in terms of ensuring people are not pushed into residential care too early. And then the unplanned hospitalisation for chronic ambulatory care sensory conditions, this is management of long-term conditions in the community, sort of a proxy for how we're doing on that. We set ourselves quite a stretched target on it, and we're only 17 off the target, so really, really small numbers off. and again, reflecting all the work that's going on in primary care and community, health coaching, social prescribing, keeping people with long-term conditions being able to manage not going into hospital for emergency appointments. That's what that measure's looking at. And the final one is improving the proportion of people discharged home from hospital. That is a really high figure and it's really good. 98% of people go back to where they came from, and we've put a good chunk of information in the report about this, and we've actually linked to a report that was taken to Adults Committee about the discharge work that's ongoing, because a number of the services in the Better Care Fund are adult social care services reported to Adults Committee as well. So we tried to make sure that we're linking in so we can also, so you can see how it comes across and how it works. But that is really fantastic. And that went to the February committee. In terms of the Section 75 agreement, we just wanted to have it noted that following the agreement of the plan from NHS England, we updated the Section 75 and it has been sealed by the council and it's been signed by the ICB. So we're compliant with the Section 75. It meets all the national conditions and the minimum contributions have all been sorted. Within the paper, we've also put a breakdown of the spend. So the Better Care Fund is only adult services. So the Section 75 includes adults and children's services. It's a much bigger pool. It reflects all our ambitions around joint working, around sort of cradle to the grave working, including transitions. The Section 75 is circa £1 billion of health and care money. The Better Care Fund is a subset of that, the adults bit, at £456 million roughly. And we've shown in the report sort of the breakdown between what the council put in and what the ICB put into this plan. We can expand it further. It's quite high level currently in here, and it reflects what's in the Section 75. So that's what you're seeing in terms of in the paper. This year also we were asked to include within the Better Care Fund reporting progress against what's called the Adult Social Care Discharge Fund that was made available in the autumn budget in November. They made 500 million available nationally. 5.6 of that came to Sheffield, 3.3 was for the ICB, 2.3 directly to the council, but we took a partnership approach to describing the schemes that we wanted to invest in to make the impact. That was at Sheffield Partnership Board. They looked at the schemes and the Oversight Committee looked at the impact. At the Urgent and Emergency Care Flow Board on the 2nd of March this month, it was reported that Sheffield's seen an improvement and an encouraging position in delayed discharge data, and that the schemes have had a direct impact on that. I've included some of the schemes in the paper if people have been able to see that in terms of the additional capacity put into enablement, additional capacity for transport. We can obviously get some more case studies out of that, but also we've included the paper that was taken to the February committee on adult health, the Adult Health and Social Care Policy Committee, that describes how that smaller pot of money is combined with other pots to make the impact. To again linking it in, but this is still being reported on, and we have to report on the impact of this at the year-end template for the Better Care Fund as well. Around the governance, previously the Better Care Fund was managed via a joint commissioning committee and executive management group. Those groups were stood down when the ICB came into inception and the CCG finished. We now are doing the business in terms of the commissioning around Section 75 agreements through the Sheffield Partnership Board, and the members of the Sheffield Partnership Board include key members here in terms of the Chair of the Health and Wellbeing Board, Council Chief Executive, Alexis as DAS, and ICB partners. So that is the governance now in terms of where we're having the discussions around Section 75, around joint commissioning, and so that there is a change in terms of where things were previously managed and where the information is going now. It's just to update the board on where Better Care Fund and joint commissioning decisions are happening in Sheffield now. Finally, it was published really recently, actually, on the 20th of March. On the 20th of March, it came down from NHS England around the requirements for the year-end report for Better Care Fund, and the requirement that this board needs to sign off that final report they've asked for it by the 23rd of May, but the next board doesn't meet till the 29th of June. So as part of the ask, we're asking the delegated sign-off for the chair and for Sandy and Alexis in terms of their roles to sign it off. Because otherwise we need to meet their timeline, unfortunately. So we're asking for that. And the next board, and this June board, will bring a full report. So we'll have the 4 years finances. We'll have Q4 performance in terms of the performance measures, and it will give us time to pull together some of the case studies around what's been happening, what we did this year, and what impact we've made. Thank you.
Okay, thank you. Any comments, questions? Greg? Oh, sorry. Go.
Thanks, Martin. I'll be quick. So I think I'm right. I think I'm right somewhere. We've got the right programmes doing the right things we want, the right governance around individual pieces of work. I think the right governance around the thing as a whole, the Health and Care Partnership Board. I think the right culture, standard operating protocols. A question about have we got the right balance between reactive and proactive and then into preventive, and we haven't, I'm sure about that, but kind of, you know, I ask that question all the time. And on the target that we're not meeting, the long-term conditions ambulatory care management, 17 admissions off a baseline of 700 or so, I'm okay about that. I think it's just random variation, to be honest. So, but both epidemiologically and statistically, whatever. So I'm pretty comfortable, and I think it's the chair's call on whether to sign off, but other people have questions too.
Great, thank you.
Thank you, Martin. I suppose mine's a comment which is about the impact and how we get that impact insight, and we use it going forward and use that as part of the transformation and the other things that we're doing to sort of plan where we invest. So really interested in how you're going to get that impact evidence together, apart from case studies, which I think are really helpful. Have you got any other plans for really kind of understanding where we've achieved impact for individuals?
I'd love to have a conversation about it. I think we spoke before this. Yeah, it'd be really good to pick that up. In terms of, we've got lots of information from lots of different sources because this pooled fund is so massive. It includes a lot of the stuff that adult social care are doing, and any sort of consultations we've done, and any consultations with staff through the community services we can pull in as well. Yeah. And any advice is duly welcome.
Yeah, and I can speak to you about that. I think it's an opportunity. Thank you.
Sandy? Oh, sorry, Kate.
Thank you. The comment rather than a question, I just wanted to sort of make the point and pay tribute to all the teams across the council and the NHS who've worked so hard on our work, particularly on delayed discharge. Clearly the extra investment has been helpful, but I don't think we should underestimate the human work that has gone into building a real sense of team and collaboration, including dealing with some difficult things. So I just want to put that on record. And I suppose the thing that keeps me awake at night is something that I think should probably keep the whole board awake at night, which is just how fragile this position will continue to be, how uncertain the ongoing funding position is, and set against the very challenging budgetary constraints we have, particularly in the council. I think we just need to be really mindful of the need to continue to take that whole system approach in the way we approach discharge, given the pressures it puts on all aspects of the sector, not just acute. So that was all I wanted to say, but thanks to the team.
Thanks, Kate. Sandy?
Thank you, and thanks, Martin, for presenting that. I just wanted to come back on Helen's point in regards to the outcomes. It has been something that we've been looking at in terms of the outcomes framework for some time now. I think we still haven't got it right, but there are numerous conversations that we've had with various organisations about how we can really make sure that patient experience feedback and more that qualitative data informs our progress and monitoring. So it is on our radar and very much wanting to be a part of that, but I think we still haven't got to a point where we're able to demonstrate impact yet in that way.
Lee?
Yes, thanks Martin for this. It was a great report. I suppose that I was sort of following on from Greg's question, and similar one I was thinking. It looks like the key targets that we're chasing are set by NHS England, is that right? They are almost without exception very secondary care focused, aren't they? High end, when everything's gone wrong, that's where we are. So I suppose my question is, what happens if we don't hit those targets? Do you know what happens if we choose other targets? You know, how much freedom do we actually have as a place? Because this is a lot of money. And maybe, you know, and what it's doing is great. And obviously the indicators that you talk about, they're important and they matter. And there's a lot of work to achieve what we are achieving. But are they the right ones? And where does that conversation happen?
Before you answer that, can I just come in with, because my point was similar. So again, just to say, amazing work in spite of the system. So we work within a system that tries to manage a very complex issue in very sort of linear ways. And between you and me, I think the linear ways are the wrong ways, and I think we've done a great job in trying to get it right. This, you know, when this comes to sort of clinical quality of care, it's really important. You know, these are largely elderly patients that, if they're inappropriately admitted to hospital, decompensate really quickly. And you can go, and we see it every day in general practice, can go from being in the 80s, late 80s, early 90s, totally independent at home, to needing nursing home care once they come out of hospital. So it is really important that we do the front end, avoid the admission bit. And I think, in line with most clinicians, a real frustration that we've got targets with really quite severe penalties or incentives attached that don't really focus on that bit. And I think we've done as much as we can in Sheffield to try and get around that, but you shouldn't have to get around it. You know, we need to trust the people that understand the system to get on with it. So again, it was just to commend everybody for this proper integrated working. So thanks to everyone. Catherine, do you want to come in?
Yeah, I think the partnership approach that you've taken has been absolutely the right way to go. We need to continue it. I think we've got an opportunity with the Healthcare Partnership Board and the priority setting that it's going through at the moment to really think about that balance between the prevention aspect and the discharge and focusing on discharge. We need to do both, but I think that board, and as it discusses where it's going to focus its efforts, needs to really consider that balance.
I'll help Martin out here. So in regards to the answers for Lee, it's a national programme with national indicators, so we are going to have to monitor them in some respects, and the Health and Wellbeing Board has a responsibility to monitor those particular targets. In terms of any additional targets, we can choose how many targets we want to measure. Going back to the outcomes, I would like to have more qualitative impact measures as part of our process, and the partnership infrastructure that we've set up in terms of the Oversight Committee and the Transformation Committee certainly have a suite of metrics that we're monitoring, and this is only one element. So discharges at the front door and flow, etc. is only one element of that approach. But if there are certain things that you want to understand and want to know more about, then we can certainly get that data. As Martin said, we're inundated with data. It's just making sure that we are looking at the right thing whilst also demonstrating we need to definitely have some impact measures within that as well to see what it actually feels like on the ground floor.
I'm very aware of time, but any more? Greg, did you? Are you sure? Yeah, brilliant. Thank you. So thank you. And I think we were asked as a board to note the update on the Better Care Fund, note the Section 75 approval, note the governance changes, and I request that the Health and Wellbeing Chair sign off the BCF 2022-23, I guess that'll be chairs, year-end template before the next meeting in June 2023. So everyone happy with that? Okay, that's great. Thank you.
Thank you.
Let's move on to the food strategy. And that is Jess.
While Jess gets up, this is Jess, who is going to talk about the food strategy, not anything else. Very briefly, this is definitely a strategy about food, not obesity. The angling and framing is very different. It's essentially a localised version of the Dimbleby Food Report, which, if you've never read, is very, very good. One of the reasons why it's here is it's too broad for a single owner. It's a really, really broad strategy. So given its cross-cutting nature, we thought we'd bring it here first. So with no further ado, Jess.
Thank you. So as Greg said, I'm here to talk about fairer, healthier, greener, a new food strategy for Sheffield. written by Sheffield City Council but been brought here today to seek wider endorsement as a strategy for the city. The food we eat has a direct and profound effect on our health and well-being. Poor nutrition is one of the leading causes of preventable ill health. I'm sure everyone in this room understands. But food's also about much more than that. Poor nutrition is a cause and consequence of income deprivation. It drives and reinforces health inequalities in a number of ways. The food we consume and throw away, the way it's produced, can help restore nature and halt climate change, or the converse of that, which is often the case at the moment. And food also plays a really important part in our local economy. So this is not just a public health food strategy, it is a kind of holistic whole systems food strategy for Sheffield that addresses multiple outcomes. The food strategy attempts to address the barriers to being able to access food that is both good for our own health and for the health of our planet, both now and into the future. Some of those being many people being unable to afford sufficient, safe, nutritious food, many people living and visiting places where unhealthy processed food is abundant and heavily marketed, meaning that healthier choices are difficult and often impossible for people, and the carbon emissions generated by our food system contribute to climate change. The effects of that threaten our future food production, and we're starting to see the effects of this already, and we need to take our urgent steps to prevent this. The scale of the problem means that strategies such as public information campaigns or helping people one by one is not an option. We need to start to do what we can to repair our broken food system. And as city anchor institutions, the collective levers and influence that we've got can and should be used to do this. For example, collectively we can control the food served in our buildings, how we use our land, the commercial partnerships we form, who we allow to advertise on our property and in our buildings, how we help those experiencing poverty to access good food, and perhaps more importantly, what can we do to prevent that poverty in the first place, as poverty is a key driver for people not being able to access the food that they need. So to that end, the board is asked to consider how can we collectively ensure the food strategy is delivered to deliver the greatest impact on health and well-being, and how can you all ensure your own relevant plans take into account the issues it raises. It's therefore recommended that the board endorses the food strategy and that member organisations review their own existing relative policies and plans in light of its content and think of any additional action that might need to be taken by them, and facilitation for that can be offered where required. And more specifically, it's recommended that member organisations commit to ensuring their catering and food procurement supports the strategy's aims, as this is a key area that we can all have a huge collective influence. And that includes a specific commitment to work towards 30% of fresh food procured being from local suppliers by 2030. And it's believed that that is done on a collective and collaborative basis, and as a priority, it will make it easier to identify and overcome any of the barriers to achieving that. Thank you.
Okay, thank you. Any questions, comments?
Thanks, Jess. Thank you for this. It's come together really well, and it's really clear, and it's actually really ambitious for any city. I'm personally very glad that we are bringing this up as something that we should aspire to. It's not going to be easy to find solutions, especially in terms of food production in the city. And I know that some of the organisations that have collaborated are looking for land where they can grow food. I know that we've had cross-party kind of meetings with some of the organisations, and we are looking at ways where we can make land that is not used available, but it's quite tricky legally to facilitate that, but hopefully we can find a way forward to ensure. But it shows how we can really address inequalities without looking at all the facets of it, and this is one of them. But we can't take it in isolation, but we need to look at it with other kind of, determinants of health. But yeah, it's fantastic, so thank you very much for bringing it here. Sorry, I'm assuming that this is going to go somewhere to be approved. Is it SNR? Okay.
Thanks, Angela. Lee?
Yeah, it was just very briefly to say thank you. It was a great report. It was really good to read. It was just so refreshing to, because one of the underlying issues here is health inequalities and obesity, and just to have that actually not as the central issue, but really understanding the complexity that lies behind that, and particularly with inequalities. I mean, it may well say this in the report, I think it did. If you want to have a healthy diet and you're on the lowest income, it's going to take 75% of your income. Well, actually, you've got to use that money to pay the bills and buy clothes and everything else. So, yeah, really, really refreshing to have this approach taken. So, thank you.
Thanks, Lee. Greg?
Thanks, Jess. I think it's a great piece of work, but I am biased. So I'd be happy to endorse. Angela picked up on some of the difficult choices around land use planning. We've got other difficult choices, sponsorship, advertising, all of that kind of stuff. Remember the last meeting we talked about commercial determinants of health. My question to you was, how aggressive would you like us to be? And the answer was really quite. The rubber will hit the road at some point, and we'll need to have some awkward conversations in that space. Of note, Bite Back are in town, and they're being quite assertive with the leader and other people. So we'll have to go there, and we should go there. One thought on the ask was that partner organisations consider this for how we enact and implement, which we should. Easy for the big ones, well, easy-ish for the big ones, the council, the various NHS institutes, much harder for the voluntary and community sector because it's much smaller, much more diverse. So I think we should sort of view it as a long-term direction and hold ourselves to account on it very, very occasionally. To pick up on Angela's question on I think we do need some stickiness within the council as an institution. And my recommendation, given the sprawling nature of it, is that we pick one committee, not 5 or 6, because it could easily land in 5 or 6 committees. My recommendation would be S&R, I think, as the best or least bad place for it to go.
Great, thanks, Greg. Any other comments? Oh, Angela?
Can we get in there, if it gets endorsed here, can we get in there quick? Because there is an S&R in April.
I may defer to the Chief Exec at that point, but this gets political, and we probably oughtn't to do political things during pre-election periods, I would suspect.
Yeah, I'm afraid I think that the April S&R is a very specific set of agenda items which avoid any risk of me having to come in and say you can't talk about that, you can't say that. So, but I think we can make sure that this is on the very first S&R back after the election for sure.
Happy to leave the politics to the experts. Catherine?
Is there any plan about socialising this with the NHS trusts in the city yet?
This is the first kind of public airing of it. There is some work behind the scenes going on that's led by the Sheffield Partnership. So there's been a number of workshops recently focusing on things like the good food economy. So there's been good engagement with the NHS Trust specifically on that one, on food and health specifically. So again, that's more from a service focus. So there's been some, but probably at the more operational level rather than at the kind of senior management level. Welcome any advice on good ways to do that.
Greg?
Yes, should do with regard to the NHS Trust. Ditto, Jess didn't say there's a whole bunch of funded work with school sector. We're doing a lot of work in healthy, sustainable food in that space, some really, really good work. So we're out there in all sorts of settings and sectors. So
great. Any other? Oh, sorry, I can't see your name.
So just a very quick one around sort of timeline and also in terms of measures of success. So I read it and noted quite a number of aspirational outcomes, and I suppose that were just two of the bits that I just picked to inquire further.
I suppose the honest answer is I deliberately didn't put a time frame on it because actually it's very long-term and aspirational, so it kind of sets out a direction of travel and an approach, which is a whole systems approach, rather than being time-limited. The next piece of work is developing more specific action plans that relate to it. They're being developed by the Sheffield Partnership, so it's the council actions plus partner actions, so they will be more smart with kind of targets towards them. It's very difficult to set very high-level targets around things like reducing obesity or improving diet or reducing the carbon impact just because of the data side of things, and also how there's multiple factors that contribute to all of those. So the devil is always how do you actually show that the things that we've done are the things that have actually had an impact, because there's so much more around it. But it's a good question. It's something I think about a lot but haven't got straightforward answers to.
I didn't have an answer either.
Hence
It was
a waffle response.
I was hopeful you would.
Brilliant, thank you. questions, comments? So I think the recommendations are pretty much covered. I think it was 8.0. So everyone happy with the recommendations and to support them? That's brilliant. Thank you. Excellent. Thank you, Jess. Should we move on? So Health and Wellbeing Board Annual Report. Greg.
Thanks, Zach. That's me. I'll be quick. Thanks to Dan, who did all the hard work on this one. Never gets credit. Cheers, Dan. So it's for noting in the main, and we said a while ago that we would do an annual report once a year, including the title for the Health and Wellbeing Board. Not so easy to document impact of the board, actually. Quite difficult. Fundamentally, it all relies on good partnership working, which I think we've got. We will all have clocked the style of board meetings has shifted quite considerably, and the nature of the meetings has shifted quite considerably, and we've tried to capture that in the annual report itself. I draw attention to sort of two specifics. One was the early years system conversation we had in, can't remember, and the complexities inherent in the early years system. I think we've got a pretty good story to tell, and I think that conversation we had drew some of those out. Second one will be the housing and health workshop that we had and what followed. A chance comment to me from the Director of Housing, she's never had a time where she knows such good relationships between the health sector and the housing sector. Our job is to continue to expand and cement that. Again, easier said than done, but it was a chance comment that came from that workshop that we did. So worth doing. And we've pushed pretty hard over the year around the voluntary community sector and how we work with the VCS, and Helen may comment on whether or not anything fundamental has shifted, but we'll continue to work hard on that because there's always more to do. Asks are, one, to endorse the report, second, to consider how we build on it as we go forward, and to ask the ICB to consider the importance of the infrastructure around supporting the partnership working at place level, which I know is easier said than done, but it relies on good partnership working, which doesn't happen by magic. One ask from me that's not in the report, but first time we've done this, so I'd welcome any thought on content, style, nature of the report itself. Does it cover the sort of stuff that you expected it to cover? We're not going to do big, glossy, glitzy launch, but it will be, well, it's obviously in the public domain now, and we will kind of formally put it out into public domain after it's been endorsed. Hopefully you endorse it. I'll stop.
Great. Thanks, Greg. Any comments? Any questions? Okay, I think you covered the recommendations, Greg, so... oh, sorry, Lee.
If nobody's going to say anything, I think I should. So I'm fairly new to the board, and still trying to get my head around a little bit actually what we do. So it was really interesting paper and really useful. But it's quite hard to measure relationships, isn't it, and influence. And I think that seems to be what this board is about, is influence. But I suppose it's a challenge to actually how influential can we be? And are there places where do we need to exercise our influence in a different way or a greater way? And it just feels like this is a chance to at least think about it.
Thanks.
That's a nice easy one for you, Greg.
Thanks, I think. One personal reflection is I think we've probably not exercised, and this is maybe a Douglas and Angela question, the board is a subcommittee of full council, and we probably do need to think on that going forward. Always has been a subcommittee of full council. So there is something there. I think it's fair to say that we have willfully tried to focus the board agenda setting on stuff that is working really very well that folk may not know about. So when folks say, oh, there's nothing going on in X, well, actually, quite often there is, and we've willfully tried to focus on that. Good begets more good. So we've tried to focus on that. But very occasionally, thorny, wicked problems, which aren't working so well, and there are plenty of those, as we all know. I don't know how one measures that. The job of the board is about 3- or 4-fold. One is to hold and set the strategy for health, called the Health and Wellbeing Strategy, which we have. It runs out next year, so we're going to start rewriting that, pick that up later. Second one is the governance arrangements for the Better Care Fund, which Martin has covered. I think we cover that perfectly adequately. The third one is the Joint Strategic Needs Assessment, which again we'll pick up on that. And the fourth one is the sort of oversight of health and care commissioning arrangements, whatever that actually means. I think we fulfil those jobs perfectly adequately. If I had to say one thing, it would be setting and holding the strategy for health, by which I mean health and well-being in its fullest sense. I have no clue how to measure the influence of the board in that space. I think we've got perfectly adequate, as far as I know, I think we've got a very good strategy, but I don't know how to measure its impact.
Thank you. I suppose what I've been reflecting on, I've been reading all these papers, and I'm thinking a lot about inequalities, because all of these relate to inequalities, don't we, is the system that we work in is set to continue inequalities. You know, from, and maybe this is too big a conversation to have now, and so, the question I ask myself is, so what can I do where I am to start to influence that and change that? You know, and then because I sit on this board, I think, well, there's a lot of us here who've got a lot of influence. You know, are we working as well as we could be to start to change the system? Because often the good work that we're doing, and we've already said it at least twice in this meeting, and we're going to say it again in another item, is in spite of the system that we work in. And we sort of almost accept the system sometimes, don't we? And I'm just wondering whether there's more we could do. And the answer might be no, and the answer might be that we're doing as much as we can, but Angela will tell me different.
Thanks, Lee, for that. We've had the same conversations in other on the steering group and how ambitious we need to be. I suppose from my point of view, I think the board has influence because each constituency represented here as each one of us has influence in their own organisation. So when we endorse something here, what I think we should do is take it back to whatever organisation or group of organisations that we represent, and use our strategy here as an overarching strategy. So, and in some of those places, that might go against what's imposed, but it's like working from within, I suppose, and it is very aspirational, but there are some kind of things that we have to do legally, and we have to check on. And I think, I don't know how it used to work before. I only have experience in the last kind of 9 months, 10 months, so I have no idea how it worked before, if it was the same, different. But yeah, that's my kind of take on it. But I think we should still be really, really ambitious in our expectations of how we want the city to be and how we want to overcome inequalities despite, the impositions from above, if you want.
Can I maybe I'll have a crack at it, because I was thinking about it too. I'm going to not make a very good job of this, but I guess there's several bits for me. For me, the public accountability, public forum bit is really important, and particularly with the NHS, I think it's really important that as all of us, clinicians, non-clinicians, we feel free to actually express opinions and perhaps differing opinions, and have a discussion in the public domain. I think that is really important. I think that's kind of basics for democracy, so that's quite important to me. The other bit for me is people talk about accountability. Unfortunately, accountability tends to mean big stick, a very big carrot, and I don't think that works either. I think we're demonstrating with the NHS at the moment that hasn't worked, and we need to move away from that. Whereas I see this as more sort of, it's conscience, that this is more about actually we bring something into the public domain, have we got the clout to do something about it in our respective organisations, and we can kind of be the conscience that maybe pushes back against some of the restrictions that we've got there, and bend it as much as you possibly can. And then I think that the thing is, we all do have significant clout within each of our organisations. And I think that's part of being on the board, is that we reach a collective view and we buy into it, and then we're responsible for trying to deliver that within our own organisations. And I hate the word hold to account, because it is interpreted as big stick, and that's not what I mean. I think it's a conscience bit of it. We need to do this because it's the right thing to do for the population of Sheffield. It's that. Now, maybe I'm very naive, but that's kind of the way I see it could work, or the way I'd like it to work. And I think we need to get more discussion where people feel confident to bring tricky conversations into the public domain. Right?
To add to the navel gazing, demonstrating influence on the whole of the machine, probably nigh on impossible. I can't do it. Bit by bit, I think we can. I'm going to pick on Jess. 6 or 7 years ago, the totality of our food offer was largely around tier 2 weight management services, which is not unimportant and does make a difference, but it ain't going to shift the population dial. We've willfully shifted that, and we've shifted the resources around that, and in lots and lots of other spaces. Just shake your head if you agree or disagree. But that shifted the way we've done that. As you've just seen, that you wouldn't have seen that strategy 5 or 6 years ago, and we will continue down that path in that particular thing that does contribute to the overall goal. How one demonstrates impact in the whole thing, I still don't know, so I'll navel gaze further on that.
Judy, Douglas?
Yeah, thanks for raising that, Lee. It's something I think about as well. One of the things that concerns me is that the people who most suffer from health inequality are not around this table by and large. And I wonder if, and they're further and further away from decision making in the new system. So I wonder if one of the roles, and Zach's almost touched on this, is to be the champion, to amplify those voices through this committee, which probably means a more purposeful strategy around linking those voices into here. I mean, at one time we had a commitment that it was nothing about us without us. So we wouldn't have a report on, I don't know, whatever, food poverty without some organisation coming along saying this is what it's like. And I wonder if some of that, you can't do a huge amount of that, and we can use what's already here, but whether we need to recommit to that amplifying of those voices so that people aren't further and further away from decision making, they're brought into the heart of it, and we could do that here.
Douglas?
Yeah, thanks. Annual report time, it's always a chance to look forward as well. And just reflecting on the two papers we've had to discuss so far. We've had the Better Care Fund, which is very much about treatment of ill people in the system with literally hundreds of millions of pounds in it. And then we've had food strategy paper, which is very much about the sort of really progressive forward-looking stuff about people, helping people keep well and dealing with some major issues in there as well. Obviously, with no budget attached to it at all. But yeah, it's a good time to look forward and look at what we're doing. So I mean, we do have some choices here, I think, in this board about what we're going to spend our time on over the course of the next year. Item 13 is the forward plan, but as with all services in all our organisations, then we've always got that choice between sort of having the routine items on the agenda of the sort of things that we used to, which are important. I mean, there's the Better Care Fund is a lot of money to account for. We've got statutory responsibilities to monitor that, but important we don't squeeze out the scope for looking at once we get the the food strategy on the table, then how that's developed and where it's going to go. Because actually I don't know yet. It's new and innovative. Greg says he wouldn't have been here 5 years ago. But it's also massively important as we look to the future. So I guess some of the choices too that we'll need to reflect on for this board.
Thanks, Douglas. Sandy?
So first thing I'd say is thank you to Dan. I do really like the report and value it, so I would appreciate that regular. So apologies to say that, but thank you. I think it's a really good report. And I think it's generated this discussion, which is really good. One thing I will just say about the health and wellbeing strategy and this board is that it is the overarching strategy for Sheffield in this space. So the health and care partnership work, that the priorities work, the strategic direction in that space all aligns to how we're going to deliver the health and wellbeing strategy. The integrated care partnership strategy, which I'll be coming on later on in the agenda, that the health and wellbeing strategy has informed the development of that. So this really has that strategic oversight, and it is up to us in terms of that forward agenda what we absolutely want to get into the detail of. I'm aware of a forward agenda item of a deep dive into a particular area. I know we've got one in mental health. It's really important to get everyone's views, the input from, as Judy said, about people involved in that area, but get everyone who's around in that strategic space really informing that approach. And as Angela said, brings in the different levels in terms of how it all shows to how we deliver and demonstrate it. So it's just demonstrating and being able to see where it all fits in with the delivery approach and governance.
Thanks, Sandy. Anyone else? Yes?
Yeah, thanks, Dan. It's helpful to see it all set out, and there's a lot of stuff that's happened actually, isn't there? So I think it's a really important point that Lee's raised, and I think actually, you know, we do have a set of statutory things that will kind of form part of what this board does, but we do have that ability to make things happen as a group of people who have made a lot of stuff happen over the last few years. I think that Judy's point is really important, but I'd like to expand on that, because I think where we can probably have some traction is to really focus in on what's working, because there are some things that are working around health inequalities. We've got some really, really good practice. We know there's a huge amount to do, and there's a huge amount of challenge around that, but can we start to use this space to build on that and to actually sort of elevate and show what does work in terms of the sort of models and the practice and the things that we're doing as a city, and maybe use that to set some principles that we hold ourselves to account to as a city, including making sure voices are in those discussions, but just in terms of the sort of values that we want to put in this space as a group of partners. I think it would be really helpful to think about that in terms of strategy delivery.
Thank you. Any other comments or questions? Great, and I think you covered the recommendations, Greg, so everyone happy? That's great. Sorry, thank you. Should we move on? So Violence Reduction Unit.
Is me.
Brilliant.
So, hi everyone. So I'm just going to do a 10-minute presentation on the Violence Reduction Unit. I will say from the outset that I am not a member of the Violence Reduction Unit, and I'm here to present about the Violence Reduction Unit, so please don't ask any difficult questions. Thank you. The Violence Reduction Unit, the formal definitions within the pack, but fundamentally it's about taking a whole population approach rather than focusing on the needs of specific individuals to tackle violent crime. We've obviously seen an explosion of violent crime nationally, and unfortunately Sheffield and South Yorkshire as a whole is no different. The aim there is to make preventing violence an everyday activity for all services, and it's very much a partnership approach. It's not taking a law enforcement focused approach, and it originally came from an approach taken in Glasgow that worked quite successfully, which was described as a public health approach, but in essence is about all services coming together to work together to tackle violent crime. Next slide, please. Thank you. So the governance arrangement. So there is an executive board, which is chaired by the Police and Crime Commissioner, Dr. Billings, and it's got senior members from a host of organisations that are articulated within there. There is an elected members reference group. I will highlight that it is South Yorkshire wide, so this is not just a Sheffield focused, but the Sheffield representative is Councillor Williams, who's the Chair of Communities. There is also a Preventing Violence Forum. That's open to any group or organisation that wants to come together and share ideas and influence the direction of the VIU. And obviously it feeds into the 4 community safety partnerships. So they are sit amongst the community safety partnership and at various subgroups within those structures to sort of be held to account and to work with us in delivering some of their objectives. So the story so far. Violence reduction units were formed 3 years ago following a Home Office grant. We were one of 20 places nationally within South Yorkshire. That's obviously expanded given the success of these areas, and many more are being rolled out. It's located in a police station. There is a small team together that are actually delivering this. So within that team, there's employees seconded from all of the different departments that you can see listed. And there is a needs assessment that's been done, and I'll come on to that. Currently they're implementing the serious violence duty, and they're implementing that South Yorkshire wide. So there's a list of priorities I don't propose to read, but in summary there's been lots of publications around violence prevention and reduction worldwide, all discussing very similar themes and making similar conclusions around specific actions that need to be taken. A South Yorkshire area profile was done and reviewed and combined with the publications and other work that's ongoing nationally and internationally, and that has resulted in us identifying these 16 priorities that we accepted there. You'll see that there is actually 17 because within South Yorkshire we've added, within Sheffield, sorry, we've added the desire to reduce and tackle poverty as one of the additional themes. Okay, so the health and wellbeing interventions specific to this, so the Violence Reduction Unit do undertake regular community engagement activity. Within the picture there you can see a knife crime bin that's been funded through the Violence Reduction Unit. The Preventing Violence forums that I referenced in an earlier slide have quite heavy representation from the voluntary sector, really valued and really help and inform and shape our offer, and they also influence where funding's going. There's grant funding of 18 activities that are currently ongoing against a range of priorities. They're listed young people, violence against women and girls, and they're things that range from funding cricket teams in certain areas right through to knife crime bins and education initiatives. Some of the bits just to sort of highlight really are the Plan B custody navigators, and I'll come on to them next, the trauma-informed training and mapping, and some of the work that's ongoing with that with different education establishments and also with partners. We're doing a domestic abuse pilot at the moment with police. That's looking at tackling some domestic abuse cases where the risk out of single incidents perhaps wouldn't reach a traditional threshold to be referred into existing multi-agency referral processes. However, the frequency and continued and prolonged exposure to harm does causes some concern, and the Violence Reduction Unit are funding some work specifically to tackle those cohorts, and that's in its early stages, but it's proven to be really successful in significantly changing some endemic domestic abuse that's been over quite a long period of time. There's a lot of work being done in the violence against women and girls space, so funding initiatives in the nighttime economies and sort of covert patrols, if you like, in the nighttime economy to identify people who are possibly perpetrators of violence against women and girls or displaying predatory behaviour, and early intervention work around that, right through to identifying and protecting safe spaces and other initiatives. So just in terms of the A&E navigators, you'll see within there the major trauma centre at the Northern General. It's a person-centred approach, so there will be a navigator within the A&E department at peak times. They'll work with an individual who attends either at risk or because of a violent injury, and they will basically work with them, identify some underlying vulnerabilities and make appropriate interventions and referrals throughout all of the range of services listed within there. We have this year started a pilot at the Sheffield Children's Hospital, targeting those people that would attend there, which children at risk of violence basically will be referred into the service and bespoke interventions will be offered to support the young person, things like your stamps, which are sort of listed within there. And again, it's that sort of taking a system approach, looking at what works well nationally with other violent reduction units and replicating that within Sheffield, and equally other people looking and replicating to deliver what we have. So the progress of that work so far, you can see listed there. The ratio of people engaged with is 2 to 1, male female, so disproportionate representation of males, 19-16 years across all of that cohort, and 30 have engaged with the service in some way. So we have had some really positive engagement. Consent has been an issue, so we were working on a consent model. so we couldn't engage with where consent hadn't been obtained, but now we're working on a presumed consent model, and that's allowed us to be more effective with interventions. Some are out of area, so that presents a challenge for us as people visiting from alternative areas, but we are still offering that support, and almost everyone that we've contacted has been receptive to that support, so that's been really positive. Just an example of some of the community projects. You'll see there an example around the Sunday Centre. The Violence Reduction Unit has funded some core costs at the Sunday Centre. So it's an entirely voluntary run weekly service, offers free meals, and a chat for around 100 street homeless or vulnerable adults in Sheffield. And then we've had paramedics starting to attend that and offering some sort of early health support, which has been really positive. And obviously the plan there is to start linking the centre closer into other charities and creating a little bit of a hub for that cohort alongside other services that are in place. So one of the questions I think that Greg posed when he invited this input was around where this board sits within that and how we can work and bring in some of the other activity that's ongoing in this space around crime, violent crime, drugs, and other matters. And I'll probably defer to you at this point, Greg, for... Correct?
You did roughly say you were going to put me on the spot. One of my sort of concerns in the background is that sort of the interface between the Violence Reduction Unit, the Community Safety Partnership, and Drug and Alcohol Treatment Service, and particularly in the context of the government have just invested massively in drug and alcohol treatment services. Actually, 50% of acquisitive crime, you'll tell me the stats are wrong, but roughly 50% of acquisitive crime is drugs related, and I think 50% homicides are drugs related. So getting people into treatment kind of matters in that context as well as matters in its own right. Helpfully, I had a really good call with Shelley Hemsley this morning, and Jason Siddall, who heads up our work on community safety. And the question that we were saying is that the set of stakeholders around policing and crime is different to the set of stakeholders around community safety, which is different to the set of stakeholders around drug and alcohol treatment. Should we all ram them together? We all agree that no, we shouldn't, because they're a different set of stakeholders. But we're all pretty assured, actually, that the behind-the-scenes stitching together is working as well as it can be. And at some point, I'll bring a report here about the investment in treatment, which is substantial. There'll be some complicating factors that got in the way over the last couple of months. But I'll bring a report on the treatment aspect of this too. So.
Yeah, thank you. And I do think it's a really sensible approach to sort of keep the three areas separate for all the reasons that Greg's articulated. So that's just a very quick tour of the Violence Reduction Unit. The work remains ongoing and will remain ongoing over the next 12 months. And that's just, I would articulate, that's not all of the work of the Violence Reduction Unit. That's a very small section of the work of the Violence Reduction Unit that's sort of been handpicked, if you like, for this audience. There is a website, and as I say, I would welcome anyone to join the partner forum or with their appropriate representative should they wish to influence change or become involved. I welcome any questions.
Thank you.
So, thanks for that, Ben. I mean, I'm really interested in this. I know that there's a lot of work that you're doing with the VCS, and I know that you're connected to Baz around some of that. I'm really interested in this idea of how you bring support around people in their safe spaces. I actually did a shift down at the Sunday service and worked with Steve and the team to serve food to people. And I think there are a lot of things that people need in their spaces, and the model of bringing paramedics into that space. I'd be really interested in what more could be done around that, and I know there are similar models that are being developed across other organisations, and you talked about bringing organisations together. We have got a conversation in Baz to look at how you bring more of a collective approach with some of the VCS organisations and shape some of the understanding about that. So I think there are things that we could connect up on there. I do think it's really important to start with the people and their needs and what makes a difference, regardless of the different services that they need to access. So, yeah, I'd really welcome this. Thank you.
Thank you.
Thank you. I was just going to say, I mean, I think it's fantastic. I mean, it's is obvious, isn't it? So, you know, prevention. And it's nice to see the police leading the way. I wish some other parts of our system could catch up, if I'm brutally honest, but great, absolutely fantastic. I guess the bit for me is the opportunity to link in other things. So I'm just looking at the homeless thing. I mean, we've got a lot of, you know, real enthusiasts doing great work around homeless, working within general practice and PCNs. And you know, it may already be linked in, but I think an opportunity for some of that. I think it just feels as if there's loads of little bits that we could kind of, although we don't want to integrate it, you know, joining it up, and it could really make a lot of sense. But really great to see this. So thank you, Greg.
Ditto, massive credit to the police for leading the way in this space. I think you've done a great job, actually. I know the money helped, but it was much more than the money, so massive credit. Apparently there's no social problem in the world that can't be solved by a public health approach to, so the Director of Public Health said. As you put me on the spot, so I'm going to put you on the spot. I'm guessing that there's fairly robust evaluation of the individual initiatives. What's the evaluation of the thing as a whole? And then what happens at the end? I've lost touch with all of this since the start of it. I'm really good to see it, but it was a fixed term period. And then what's the exit plan or continuation plan?
Funding's annual. The funding's been secured. It fluctuates, it will be fair to say. So, and the grants awarded are on public record. It'd be no secret to say that in the 3 years of existence have increased and then decreased again this year. And there's various implications of that around some of the other activity. In terms of the evaluation of the violence reduction unit, there is a range of evaluative tools, so ranging from things such as knife crime admissions or people admitted to hospital with bladed injuries, both under 25 and over 25. That's tracked. Homicides, serious violent crime rates, outcomes, and so there's a broad selection of sort of evaluation measures. The VIU is also quite interesting. They've taken quite a qualitative approach to some of this. So some of the assessments of measures of impact really have been quite qualitative. So actually surveys of service users and other things and people with lived experience to understand what works well for them. And that's been really good, and actually releasing some of that control traditionally that we might hold around commissioning of services to other people and allowing these almost service users and commissioned bodies to drive some of that activity. And the activity with Always an Alternative, which is a picture within there, is a prime example of that. So that's very much a stakeholder-led piece rather than us going and saying this is what we think you need. It's more, you know, they're leading, commissioned and delivering.
Yep. Quick question for me. It talks about an approved standard for a trauma-informed approach, or an approved standard for South Yorkshire. Is that a standard that exists, or is it a thing to be worked towards?
My understanding is it's a thing that's to be worked towards, rather than an approved existing standard.
Okay, now that's interesting. Have we any idea about timescales, or whether it's sort of like to happen, or is just on the wish list of stuff?
I can come back to you with that.
Yeah, I'd be interested. Just want a quick plug. So Sunday Centre is something that one of the things that we fund as ward councillors, just because my ward covers the city centre. And one of the things that actually does contribute towards violence reduction is we've had a regular meeting over the last few years of bringing together police, but all the voluntary agencies, also all the people who are working with the street cohort, as the sometimes known, in the city centre. And Sunday Centre's part of that. So, yeah, there is another one of these groups where there's a lot of good work going on. So, nice one.
It very much is, and you'll have seen the recent road closure on Carver Street within your area again, heavily violence reduction unit funded and managed and delivered that, and really making a positive difference in a lot of ways. So, thank you.
Greg, did you want?
I'll just help Ben out on the standards on trauma informed. Yeah, yes, sort of. Zoe Brownlee is the keeper of the standard, who's Children's Hospital employee, clinical psychologist, I think, by training. She's the kind of keeper of standard. The city's done an awful lot around trauma informed training for frontline practitioners of many different flavours across lots of different organisation settings and sectors, trying actually to bring it together at the moment, and the banner for that may well be trauma-informed, it may well be ACE-informed, it may well be compassionate, it may well be any number of the above. We've done the sort of the front-line trauma-informed training, and there's more to do there, and the next step is the sort of what does that look like in the way that the institutions work? Because, okay, frontline practitioners being trauma-informed, but if the institution forces you to not go that way, then there's some work to do there. But the standard is probably not quite as nailed down as one might think, but we do have a sort of a set of standards and a set of quality assurance around that process, which Zoe is largely the keeper of. She does a great job too.
Great, thanks. And I think you just let Ben off that hook.
Yeah.
Thank you.
Fantastic, thank you. Any other comments? Just to say, it's really hard to see who's next comment-wise, and so please, if I miss you, just shout up. So it's not intentional, but it's quite difficult to see who's next. So, anyone else with any comments or questions? And I think we were just asked to receive the presentation and have a discussion and raise any questions. I don't think there are any actual sort of recommendations for Health and Wellbeing Board. So thank you. So we've now got a coffee break for 10 minutes. So I make it 25 past. Should we say 25 to come back and restart again? Thank you. Okay, I'm going to make a start. So, integrated care strategies, Sandy.
Thank you, Chair. So I'd like to present the final version of the integrated care strategy for South Yorkshire. As everyone knows, the Health and Care Act came into fruition last year with a requirement of closer integrated working between local authority and health partners. It was required that an integrated care partnership was formed, and South Yorkshire was formed in September 2022 and has membership from each of the health and wellbeing boards across the 4 places, so that's Sheffield, Barnsley, Rotherham and Doncaster, and therefore members from this board are on that partnership board itself. So the purpose of the Integrated Care Partnership was to oversee the development and delivery of the Integrated Care Strategy, which has come to board today for endorsement. So this is now the final version, and it's to make board members aware that there was quite a tight national framework and timeline for this strategy. There was a requirement that the strategy was initially developed by December last year and then subsequently finalised, as it has done last week. The strategy itself is a refresh of the South Yorkshire Population Health Needs Assessment, and has also been informed by an extensive engagement and looking at existing engagement with patients and public, and insights from that engagement and campaign has been informed into the strategy itself. And it also builds upon each of the individual places' health and wellbeing board strategies as well. So it very much, as you'll see within this strategy document, a lot of it you should recognise from our own strategy. So I wasn't going to say much more than introduce the strategy, but I will hand over to Greg, who is one of the ICP members, just to give a bit more context.
Thanks, Sandy. I'll be quick. So Angela, Alexis, Helen, Julianne Hall from South Yorkshire Housing Association, myself, are all members of the ICP. So we've got our fingerprints on it. You can shout at us if you don't like it. So it's here for endorsement. I'll do a brief note on sort of what changed between drafts to final. There was a big push on getting the health and care assets and the economic and other contribution that health and care assets make to make to South Yorkshire, particularly the Centre for Child Technology, but other. big push on getting commercial determinants of health more explicitly referenced and tackling some of that head on. And you'll have noticed I'm being quite angsty about that at the moment. There will be pushback and we will need to deal with the pushback. Big shift on active travel and public transport investment. Enormous investments being made in South Yorkshire on that context. A good chunk of which is around active travel. So we obviously capitalise on that. Ditto housing stock. And we know that it will evolve. It's probably not fixed point in time strategy. The framing of it has shifted a bit, shifted quite a lot from individually oriented stuff where we change things one person by one person, one patient by one patient, one citizen by one citizen, shift to structural determinants, and the framing of what contributes to health. Early on we were talking about the £3.6 billion health and care spend. Well, actually the health system is the sum total of all of our communities, voluntary and community sector, government at various levels and the NHS. So, you know, the 16 billion quid, that's the totality of public sector spend and then beyond. And we framed it willfully in that context. Obviously has, oh, chocolate, thanks. Obviously has links to the Mayor's ambitions around inequalities in healthy life expectancy, and obviously, as Sandy said, has kind of is rooted in the existing 4 health and wellbeing strategies. Those are the building blocks, and hopefully you'll see the direct line of sight. And it will be subservient to that. The business end of this is the Health and Wellbeing Board. We still retain statutory responsibility, but we were told by government to have a ICP strategy. We have one, and it's here for your endorsement, and I shall stop there and eat some chocolate.
Thank you, Greg. Any questions, comments? Lee? No? Lee and then Judy?
Yeah, thank you so much. It was really good reading this, and it's really, the aspirations in it are really welcome, and the desire to do things differently and work in partnership, absolutely welcome. But I was just wondering, how do I respond to this? Because all of that is really, really welcome. But as we talked about before, it's set against a backdrop of systems that stop us doing the right thing. And I suppose, and it's fine to have angst about that, isn't it? And lose sleep over it and stay awake at night and think, oh, what can I do? But actually, I suppose I was thinking, how could we frame it in a question that's useful for this board? Because health inequalities looks to me, where I work at Firth Park, I can go into at the back of the reception area where patients can't see it, and there's a board that's got the names of all the people that have died recently. And their date of birth is on there. And I was there a few weeks ago, and over half of the people who had died had been born in the 1960s and 1970s. So I was born in 1966. I know it's hard to believe it, but those are all people who are younger than me. And health inequalities means that people who are younger than me become ill and can't work and can't earn money, can't pay their taxes, can't pay into the economy, can't help support their kids in the same way. Kids, do you know, that's what inequalities looks like. And I know that we know it. But when we look at things like that's quoted in here, so we're going to focus on, particularly thinking about health, we're going to focus on Core 20+5, which is really sort of powering in on the people living in the 20% most deprived populations, and look at these factors that we know are leading to ill health and early death. That's fantastic and that's great. But I know there are GP practices in Sheffield, all their patients are in the 20 most deprived populations. And there are practices where none of their patients are in that population, and yet the practices in the more affluent areas are getting more money. So how does that stack up? And that's nothing to do with the intentions behind this, but it's an illustration of what we're up against. And, you know, and so the centre can talk about we are absolutely committed to inequalities, but the practical realities are, no, they're not. And so what can we do differently? And if you come from a deprived background, you're less likely to be able to see your GP, you're less likely to get a diagnosis, you're less likely to have a referral to hospital, you're less likely to receive that referral from the hospital. If you get to hospital, you're less likely to be able to get there. If you do get there, you're less likely to have imaging and investigations, and if you do get those, you're less likely to get the treatment that other people get from a more affluent area. Well, what's that about, and why is that, and why do we just accept it? So sorry, it's a bit of a rant. It keeps me awake at night a lot. You know, how long do we just accept that this is the way it is? Or how much can we, as a system in Sheffield, and particularly South Yorkshire, push back on the system as it is that stops us doing the right things and stops us from really achieving the stuff we want to do in here? Now, all that said, there's masses in here that's really good about community working and community assets and community enabling and health prevention, health promotion, which is absolutely the way to, illness prevention, health promotion, which is absolutely the way to go. But then the reality is, as an ICB, we're held to targets that are all about something completely different at the other end. So I suppose, again, it's that question, absolutely welcoming this. It's really, really brilliant work. But what can we do to enable this to happen?
Thanks, Lee. Judy?
Well, mine's a point about the system as well, I suppose, but a slightly different one. I think what's in here is really good and I support it. And it's great it's been built on local priorities and talking to local people. But I want to pick up on the 30% cuts that are coming along. I guess if I was running it, I would, to achieve those cuts, I'd be centralising. And that concerns me because I think that this board needs to be worried about what will happen to the local engagement work, to the local accountability to the citizens of Sheffield for their health service, given that a third being cut. That seems to me to be really serious. And already, I think decision-making is retreating for many people. Where is it? How do we get involved? If that's going to get worse, does this board have a view about that? And should we be making representation politically and in any other way? I think we should, because not everywhere is the same. Sheffield isn't the same as Doncaster, and we need to make sure the system doesn't centralise and bland out those differences and then not work on the sorts of things that Lee's been describing in Firth Park. So what are we doing about that 30%?
Can I come in there just quickly? So I share your concern, Judy. We need to do the opposite. We need to be moving it down to the people that are on the ground. So the people who understand the local population quite often are the local population and the people that work there on the front line. You need a decentralisation. You need to move. And we need to get back to a level of trust. I spoke to a clinician the other day and he said it's demoralising that the system, if you follow the rules, the system stops you doing the right thing for your patient. And I think that is a really sad position to be in. And the response from that individual was, this is a job that I love, but I'm not going to do it for much longer if that doesn't change. So that is my big fear, is that we need the opposite. We need to start trusting each other. We need to offer a degree of autonomy to the people that really understand what needs to happen. And if through the cuts that we're getting, you get the opposite to that, then I think we really are in big trouble. So, I mean, the good news is we've had assurance. We were at an MP's meeting last week with Gavin and Pierce from the ICB, both of whom gave the assurance that there would be autonomy for place and there would be enough staff within place to deliver the priorities that we have to do within place. So it was really good to hear that from them. And I know the local politicians are really on board with trying to make sure that that happens. But that is my big fear. And it's really difficult because we're also talking about people that are very dedicated people who really come to do the right job. Sometimes within the system, they don't have the flexibility to do the right thing. I think sometimes when you get these things about, I think it was described as, bonfire of the bureaucrats, which I think is really quite offensive. So I do worry. We want to cut the costs and we want to put as much as possible to the front line within the NHS, but you do need people to help deliver that. And so I share your concerns, Judy. I just hope that the assurances we've been given and the way it pans out actually keeps that autonomy for place. It's really important. Anyone else? Angela.
Hi, Ellie. Thank you so much for raising, for bringing that kind of question here in terms of how we're going to do it and how we're going to ensure that we do the right thing. Having been involved on this ICP since September, what has been really refreshing is the fact that we've all been in the same room together and the strategy has been put together by all of us from all 4 places, with people from the NHS, from the voluntary sector. And in Sheffield, we deliberately wanted to get away from just having people from the council, and therefore we asked people from outside the council to be there with us. And that conversation, that, you know, what you just said, is a conversation that we've had in the room, and we have talked about allocating resources where they're most needed. And so how do we do it? We just have to see how it pans out. But we have talked about accountability, and we have talked about reviewing, although we haven't got a timeline for when we're going to look at the strategy again and see how it works on the ground. But we just need to give it time to, you know, to have a plan of delivery, if you want, of the strategy. But the thing that, for me, you know, I want to be hopeful, because otherwise it's really depressing, you know, having a story like that, because it is repeated across the city, you know, thousands of times. I think the way people work together from the different parts, the NHS, the primary care, the bureaucrats, the local councillors, the voluntary sector organisation, public health, etc., it's been very positive, and we've done lots of workshops and we've brainstormed, and all of those conversations have happened in a room where there's been lots of people, and it has been very kind of forward-looking, and it's felt different. So what we have talked about is how do we ensure that those who need to be accountable are accountable to this strategy. And I suppose that's the reason why it's so kind of general, because the 4 places are very different, with different needs, and we needed to have something overarching, ambitious, but overarching, so that it didn't kind of feel too Sheffield-centric or too Doncaster-centric, etc. But, you know, if we can work together and we can put in practice what we preach in that strategy, I think we can achieve something. But it's not something that we can, you know, can do it in 2 years, 3 years. It's a long-term thing, although there are, as you can imagine, 2-year plans and 5-year plans. But we have also talked about things that are not measurable by you know, they're not, that you cannot measure, and give targets for some of the things that we want to achieve in terms of inequalities. So I want to stay hopeful.
Greg?
So we've definitely tried to make it not Sheffield-centric, and we tried really hard on that one. And I would recommend the board kind of adopt it, recommend it, endorse it. Just to come back on some of your points, Lee, I think you're being the conscience of the board today, and well done for it. I suppose think through the last 10 years. There have been 10 difficult years public sector investment-wise. We've just about held the gap, actually, in healthy life expectancy. So that hasn't happened by magic. It's happened because we've consistently done the right thing. It hasn't got better, and that remains not good enough, but it hasn't got substantially worse in that period. That has been a willful act of commission. Hasn't happened serendipitously. We've continued to do the right thing through some difficult times, and we talk a little bit about chunk by chunk here. We've talked about food this morning. We're going to talk food earlier. We're going to talk about physical activity in a minute, culture in a minute, etc. We can each come up with stories. In terms of the big macro system, the ultimate, the pinch point is the money. The point of a good chunk of this is shifting the money leftwards, upstream, however you want to phrase it. And there is something about the machine in the NHS has to either choose to or choose not to make good on that. And that is an act of omission or commission. And there perhaps is something about the chair, I'm inciting the chairs of the Health and Wellbeing Board to do this. You choose whether or not you want to. But sort of making that point absolutely clear, as either of you two have said, from a primary care perspective, people are thinking, I've had enough of this, and that will be a problem. They're more likely to have had enough in the more deprived parts of town. That bit really needs to change, and I think it's worth making that abundantly clear. Yes, of course we endorse the strategy, it's a good strategy, but the point has to, the proof has to be in the pudding, and there's some kind of examples where we shift the money away from the acute management of bad stuff, which let's not pretend isn't unimportant, because it is, but we know that we can do as good as or more by shifting the resource. So we will continue to do the right thing in the interim, however.
Thank you. And I think just to stress that shift of resource isn't actually saying for general practice primary care, it's actually pre that. You know, it's voluntary sector, it's local support, it's community support type stuff that will really make the difference. So, but we're going to have to be brave enough to do that. Lee, do you want to come back in?
I'll just come back on that, because I really commend this report. And I didn't want to be negative about it at all, and didn't want to not remain hopeful. You know, if we weren't hopeful, we wouldn't be here. So I am hopeful, and you know, and actually even that challenge of a lot of the, obviously just speaking from a GP point of view, a lot of the GPs in the most deprived areas are the most committed people. You know, they are sticking out regardless and absolutely recognise what has been happening over the last 10 years and the good decisions that are being made. But it is that reality. Sometimes it just feels a little bit like shifting the deck chairs, and the resource never matches the need. It's, you know, so Marmot talks about proportionate universalism, doesn't it? You know, that doesn't happen. And it just struck me that, you know, if you were a country that had just experienced an earthquake, would you send your rescue teams distributed evenly across the country? Because that's fair. Do you know? No, you wouldn't. You'd send it to the places where the need is greatest, where the lives are most at risk, because that's the right thing to do. And we seem to struggle to do that as a country. And again, I don't want to, you know, it's not about conscience and it's not about, you know, philosophy, but it's sort of, it's using the grit that we've got to be, and so maybe it will be, you know, a letter from the chair back to the centre to go, you know, we've really got these aspirations, these ambitions, and, you know, maybe Oliver Coppard will be involved as well, you know, we've got these ambitions, but they will be very, very limited if actually the structural way that we shift money around doesn't match the need.
Thanks, Lee. I think sort of linked to that, the other bit I'd be really interested in, I think it would really help us as a board, is to try and get some understanding of where the resources sit within the system. So one of the things I'm really keen on is that we actually look at NHS and social care spend, but where do we spend the money? You know, how much do we spend in each part of the system? And what I'd really then love from our public health colleagues is actually if we moved that money to other parts of the system, and I'm only saying this because I kind of know the answer, but where would we get the biggest benefit? And I think part of that is also looking at things like, you know, general practice, because you're right. I mean, the GP contract is so unfair to practices in the most deprived areas. It really is. It's so much easier to run a GP practice. I'm going to get hammered by some GPs here now, but I'm going to say it. In a leafy suburb, it is much easier to run your practice, particularly when things are getting very tight. And so, you know, and we are really lucky in Sheffield because we've got a lot of altruists that really do it, not for the money, but they do it because they want to do it for the communities. So I would love to look at that. I think it'd be really useful for us to understand the landscape by understanding where the investment actually sits within the landscape. Because you're right, unless we get that shift, we're never going to do this. And I really don't, I've been doing this for 25 years now. I've almost get to the part I need another office for NHS strategies because we love producing strategies, and then we reorganise every time the strategy is just about to make a difference. So I really don't want this to be another one of these. I don't think it will, because I guess the challenge back is it's up to us to actually deliver this. Right?
So on the money point, Chris Gibbons has already started that at Jackie Mill's request. So I don't know his timescale for producing it, but he's already started that, and it's precisely that question. I've said to Chris I might expand it well beyond the confines of the ICB budget, but certainly we'll start there.
Great, thank you. Any other comments, questions, Douglas?
Bit tangential, but just throwing something in from the sort of the housing point of view. I think we probably also need to use any levers with government at whatever levels to make that point. Just, I mean, what is encouraging is more of a a growing awareness of the link between health and housing. But for instance, just the other day, I managed to speak to some officials at DLUC who were visiting the city, really positive. They went to see some local authority housing. They were quite surprised. But we were talking about the health impacts of them. I just want to make that point. So they're involved with housing. I want to make the point of health impacts of people living in substandard housing, or even housing that's sort of barely adequate, but still has an impact on their health there. And just getting them to think about some basic questions like, at what point do we get the health service providing repairs on prescription? You know, so if, as a GP, someone comes to you and they're suffering from asthma and lots of other things arising from mould in the house, which arises from a damp issue, it's something where, so they identified that we often get, GPs writing into the council saying, can you help this person with housing? But actually, the story of social housing and private landlord housing is that, there are loads of these letters going about, but no action is often taken. I'm not saying that happens in the local authority. I know in the local authority we're really driving to make sure those cases are dealt with as a priority, and that's also being driven at national level now. It's become a bit of a thing. But actually, when do we say the health service is going to say, right, I can put repairs on prescription? There will be a new system put in to require that to happen. Because actually, for a child living in a severely mouldy house, that is probably the best health intervention that can be done. It's just not something that really arises in the system at the moment, but I'm just throwing that in as a bit of random thinking there.
Interesting. Thanks, Douglas. Anyone else? Lee?
We have that happening a little bit already. So at the Foundry PCN, I was talking to one of their care coordinators, children frequently attending with asthma, never had asthma before they lived in this house. And so she went and visited the home, and actually, yes, it was very damp and very mouldy, and was straight on with the housing. So it's not quite a sort of repair on prescription, but it's the health service realising what the root cause is and actually doing something about it. So, but working in partnership is always going to be the best way forward. Yeah.
Any other questions, comments? Okay, thanks everyone. So I think we're asked to, the board are asked to endorse the integrated care strategy for South Yorkshire. So everyone happy? Great, thank you. Should we move on? So physical activity and leisure.
So whilst Anna and Kate get set up, so there's a short paper. I think the paper doesn't do justice to the amazing stuff that is going on in the city. Hopefully Anna and Kate are going to rectify that. We've had a long-established physical activity strategy. We set out to be the sweatiest of the core cities. We've done okay in that regard. We did quite well. That probably underplays a lot of the amazingness that goes on day in, day out in multiple settings and contexts to encourage us to be physically active. And with that, I'll hand over to Anna and Kate.
Brilliant. Thank you, Greg. Thanks, everyone, for inviting us to talk about physical activity today. I'm Anna Lowe. I'm Director of the National Centre for Sport and Exercise Medicine in Sheffield, and I have the privilege of overseeing our whole systems approach to physical activity in Sheffield. So Kate and I, between us, are going to talk to you for a few minutes and just bring some of the information in the paper to life, hopefully, and then we have a couple of questions to follow up with afterwards. So as Greg said, we have a progressive approach to increasing physical activity across Sheffield. We have a 5-year strategy in place. Our approach is called Move More. You might have come across it in many different ways. We try and look at the breadth of benefits to becoming a more active city. So we focus very much on the individual benefits of preventing and managing long-term conditions. We know that we have a large proportion of the population in Sheffield who have a health condition higher than the national average, and we know that physical activity is really important in preventing and managing, and actually in some cases actually modifying disease processes directly as well. We also focus on the huge benefits to communities in terms of growing community cohesion, directing people away from crime, reducing antisocial behaviour, all of those really important community benefits that physical activity brings. We also focus on benefits to the economy in terms of happy, healthy, productive workforces, considering that we're all going to be working longer, and that's really, really important. And there's many synergies with environmental agendas in terms of the more people we can get walking and cycling, the fewer people are using cars, and that's better for our health and better for the environment. So we try and take a very rounded view. It's not just about individual benefit. There are multiple layers of benefit to Sheffield in becoming more active. So in our strategy, in our Move More strategy, we recognise that it is complex. Physical inactivity is an intractable problem, and we need a progressive approach to it. We know there's no silver bullet. We know there's no single organisation, no single initiative or programme or funding pot that can solve this. We have to think differently, and we have to work together right across the city and have a multi-sector, multi-organisational approach. So we divide the work that we do in Sheffield broadly across 6 key areas. So we have sport, we have active travel, we have communities, healthcare, education and environments. So taking a very broad view of all the things that influence whether we're active across a day, a week, a year or not. Our whole systems approach is currently governed by the National Centre for Sport and Exercise Medicine Board. We met this morning. We have broad representation from anchor organisations across the city, and one of the things we wanted to talk to you about today is how that board can connect with this board meaningfully so that we support one another's agendas and feed into the broader citywide conversation. The strategy is very focused on inequality and the role of physical activity in reducing inequality and mitigating some of the impacts of inequality on health in particular. So we're unashamed in our focus of supporting where need is greatest and diverting resource to where need is greatest across the city, and that's really evident in everything we do in the name of Move More. So I'll stop talking there. I think Kate's going to talk for a couple of minutes on This Girl Can to start with, and then I'll pick up on healthcare.
Hi everyone, I'm Kate Clark. I'm a service manager within the Sport, Leisure and Health team at Sheffield City Council. And as Anna says, there's a huge amount of work taking place across the city, and we just wanted to give you an example of one of the projects that we've worked on, particularly kind of focused in communities in Sheffield. This Girl Can was funded through Sport England funding and gave an opportunity for a local campaign to encourage women and girls to get more active. As part of that grant came to Sheffield City Council, but we know that the VC sector is very well placed to kind of deliver that sort of work. So we gave opportunity for people keeping well organisations to apply for that funding. We had 4 organisations that got involved in that This Girl Can project to deliver a campaign in their local area, which looked at kind of testing different things to see what would help increase activity around women and girls. They tested a number of things in terms of developing a forum to share and inspire and encourage and also kind of raise awareness of the campaign. They also delivered a programme of physical activities within each local area, build capacity within the system, so looking in their organisations at using some of the funding to focus staff time on physical activity and building on that. And those things all kind of helped increase activity in women and girls. The other kind of key thing they did within the local communities was recruit volunteers as local physical activity ambassadors, This Girl Can ambassadors, who then worked within the local communities where they had, you know, a huge amount of knowledge and kind of connections within those communities or particular skills that they could pass on. And those volunteers got involved in running activities as part of that programme. It was somewhat hampered by COVID, as it happened through part of the COVID restrictions, and was adapted, so there was online activities as well as outdoor physical activity. But through the evaluation we carried out as part of that project, all of the kind of projects or interventions that took place helped increase activity, but there was very much a kind of, depending on the demographic, the location, the assets within that community, things worked better in certain communities than others. And what we do within the Move More and the projects we're working on is make sure we incorporate evaluation into that so we can then use that and build on that. So with projects like This Girl Can and Move More Empowered Communities, which was led by Voluntary Action Sheffield, we then use that information to kind of build and move forward on other projects we're planning. there's obviously legacy that's come out of that as well, embedding physical activity into some of those organisations and the benefits of that, and allowing connections and networking across the city. So, for example, with our British Cycling Partnership, where we're targeting opportunities for cycling across the city, they've been able to kind of link in with This Girl Can officers and those links within the community, with the coaches of them being able to kind of develop that trust, because there's already those links within the community, which has allowed additional activities with women and girls across a number of different organisations. So I guess that's just a little example of one of the things we've done. I'll pass back over to Anna to talk about healthcare, I think.
Brilliant. Thanks, Kate. Yeah, so I just wanted to follow that with one other example of some strategic work that we're doing across the city at the moment, and this really relates to how we can connect in with healthcare partners across the city, and really try to bridge the links between healthcare and other physical activity provision across the city. And I'm really pleased that I was here to hear what you were saying, Dr. Sorsby, about the challenges that people face in primary care. I think there's huge opportunity in Sheffield to embed physical activity more centrally in healthcare systems and services and processes, and there's a whole range of projects that are coming together, sort of coalescing around that at the moment, and I think that in Sheffield we're really primed to have impact there. So some of those projects we have are ongoing. So, for example, we have 3 co-located centres, so community leisure centres that co-locate NHS services, and we're evaluating that, and they're high delivery, high throughput centres, and that gives them the opportunity for patients to attend an NHS appointment in a non-traditional setting and have really good conversation about physical activity and exposure to leisure services as well. We're working across some big research projects, the cancer prehab, for example, and also looking at elective backlog in terms of orthopaedic surgery, hip and knee replacements specifically, looking at how we can support people who are facing a long wait and how we can improve their self-management through access to physical activity and support. We're working with providers across the city to look at our exercise referral scheme, so looking at SPARS, the Sheffield Physical Activity Referral Scheme, and how we can improve that and modernise it and make it a more accessible and equitable service across the city, so that whenever a healthcare professional thinks that a patient might benefit from becoming more active, there are easy solutions at their fingertips, and it very much ties in with the whole social prescribing agenda as well. We also have a growing alliance of very passionate, motivated healthcare professionals who want to engage on physical activity and want to do more and want to improve their services by integrating physical activity. So we're working with that group, and that group's growing all the time, and they are very, very motivated, and I think that together they'll support the work that's going on. We've also had a lot of funding into the city in terms of academic projects in this area. We've had the Active Hospitals pilot at the Children's Hospital, and so there's a whole load of activity. That's just a few examples in this space, and I think it very much speaks to the conversation you were having earlier about how we can really try to bring prevention more centrally into healthcare through physical activity. I'll pass back to you, Kate, for the last bit.
Just a couple of minutes. Yeah, the other thing we wanted to talk about today was around the co-location, obviously you've referred to as well. We've already got some co-located facilities, healthcare facilities at Concord, Thorncliffe and Graves leisure centres. As part of the investment Sheffield City Council will be doing in our wider kind of sport and leisure centres over the next 10 years, co-located healthcare and community facilities is something we're looking at very closely, wanting to expand on what we have already at some of our centres. That investment is currently going through a review in terms of the kind of financial model of that, but previously we were looking at kind of rebuilds of Springs and Concord Leisure Centre, along with works to Hillsborough and Potton's Forge. The consultation we did as part of our sport and leisure strategy strongly supported kind of co-located facilities from including healthcare, but also things such as youth services within those centres. And part of the kind of consultation we did with target communities raised the issue that many people don't feel like there are places for them in our sport and leisure centre. So creating more of a kind of health and wellbeing centre is something we're really keen to kind of move forward on. So one of the things we wanted to discuss today really was how we kind of can work together and how partners in the Health and Wellbeing Board can contribute to that co-design process to make sure what we deliver or we develop in the new facilities as we redevelop them meets the needs of the communities, but also does, as you know, is the best we can do for tackling health inequalities across the city. So I think that's something we'd want to get feedback on today as well.
Great, thank you. Just to thank everyone for all the hard work. I mean, this is something we should be very proud of. So all the hard work is appreciated. I'm very aware of the time, and I think with the questions, the recommendations, we're probably not going to answer them all today. But if anyone wants to make any comments or any questions, and then I'm guessing what we'll probably do is take away the questions, the recommendations, and take them back. Angela?
Just very quickly, it's fantastic. Thank you very, very much for the report and the presentation, more importantly. I just wonder how we're linking this with the kind of threat of our major leisure facilities with the end of the contract with the Sheffield City Trust, because obviously what happens in communities is super important, but some of the facilities that are a risk are also used by some of our communities, and how we're going to talk to the other bit of the council so that we don't lose track of the fact of how important those facilities are for the health and well-being of some of our most vulnerable citizens.
That's all part of the work that our team within the council are leading on at the moment, and the procurement of that, the leisure services operator is something we're working on at the moment, and yeah, we kind of completely know how important those are in terms of health and well-being. The other thing we're looking at as part of that procurement and new contract will be a much kind of wider approach to community outreach and making sure we also come out of those buildings and work with communities to activate spaces and come into kind of parks and open spaces as well. So as well as what happens within the buildings, there'll also be opportunity kind of out within the communities, and that will be something else that we want very much to kind of understand what's happening in terms of inequalities and where we need to focus that activity that comes out of those buildings. So I'm totally in agreement with what you're saying in terms of how important they are, and particularly some of those within communities that are serving them. But we also know from our consultation that there's some people who don't want to come into our facilities and may never come into our facilities. So we're looking at a way of the operators from those facilities doing more out in the communities as part of that contract as well.
Judy?
Yeah, can I pick up on that point about the Sheffield City Trust? Because I understand the model of it is about cross-subsidising from profit-making to non-profit making, and I worry that that model may go if there's a commercialisation of an aspect of it. So I don't need to answer that, but if I can leave that, I think it's a really critical thing, whoever provides, because we could end up with poor services for poor people. And just one other thing, you picked up the ambition about walking or cycling. The Healthwatch did some work around that, and one of the other points that came up was quite a number of people really want good bus services because they can't walk or cycle. So I would really want not to be confined to that. I think it needs to be more nuanced.
Thanks, Judy. Douglas?
Yeah, that's right. I was just thinking about question really, what's the relative balance between sort of the leisure organised sports facilities and the getting people moving in an unstructured environment like walking in parks. What's the relative balance of the importance of those in terms of getting people healthier in the broadest sense?
I think different people have different views on that. I think from a strategy point of view, the way we talk about it is that there are 6 areas, one of which is our sort of environments and facilities, but they're all really, really important. And, you know, physical activity, your levels of physical activity are determined by so many different factors, including how you experience work and school and active travel and your proximity to green space. And we know that many people will be very active without ever stepping foot inside a facility. So I think it varies person to person, and people's views on importance will vary as well. Our view is that it all matters.
Thank you. Greg, next.
So, cheers. Three quick thoughts. One, agree with points Judy made around kind of building social value into contracts. It kind of really, really matters, and it's really hard to specify. Well, it's not hard to specify in contracts, but it's hard to kind of live the specification at the end of it. So I think, but it does matter, and we forget that at our peril. Second one, I would encourage that we do sort of support the principle of co-location. The nuances will vary from site to site according to the operational conditions on the ground, but the principle of co-location is really important. I would recommend that we support that. Third one, just a push from me, sort of a personal push. The one thing I think we could do better is moving more in early to middle age on the prevention of frailty. Lifting stuff and sweating prevents frailty. That will prevent umpteen thousand problems further down the line. I don't think our messaging and or our activity is as strong as it could be in that space. So I'd really, really want to push there.
Sorry, Zach, I know you're wanting to move on. I just wanted to very quickly say thank you, and I really appreciate the work that you're doing. And I have been involved in some of the work through the Move More Empowering Communities activity. What I think that we're getting from that wealth of things that you're doing is a really good, robust evidence base about how you get into some of that health inequalities and you do make an impact. And I think actually bringing that together with the discussion about where do we put our money, where do we put our effort, and actually how do we join that up? Because some of that activity has produced some amazing models that actually connect people who were previously a million miles away from doing physical activity. What we don't have is a sustainable approach to investing in that stuff that works, that is going to make an impact. And we need to bring it together. We need to not do this amazing stuff and then just say, oh, well, that was nice, what next? I think we need to build on it and we need to bring it in. So that's my plea, that we actually think, how do we take the good practice, the innovative stuff, and how do we kind of embed that into our city approach?
Thank you. Very good point. Thank you. So I think probably anyone else with any, or should we move on? So just to thank you, I think the questions, the recommendations, I think from the conversation, clearly we're keen to be involved. So why don't we take them away, and then we'll get back to you, and certainly we'd be keen to have some regular updates. But I mean, certainly personally, I'd be really keen to be involved and support as well. So if there is anything I can do, please just let me know. Thank you. Should we move on? So next we've got arts, culture and health.
Whilst Kim and Steve set up, I'll do again a quick intro. So in November last year, the Council and Sheffield Museums facilitated Culture and Health Symposium, Millennium Galleries, I think it was. Excellent work highlighted there. The main report is the sort of synopsis of that. Lots and lots and lots of culture and lots of NHS stakeholders there, lots of good stuff. Probably not as well connected as it could be, and the purpose of the conversation now is how we get the right connections.
Okay, thank you. We're going to do a bit of a brief presentation, but before we begin, my name is Kim Streets. I'm Chief Executive of Sheffield Museums, and this is...
Professor Steve Haig. I'm from Sheffield Hallam University. I founded the Advanced Wellbeing Research Centre out in Attercliffe, where Move More is based. I've worked with Move More for many years. And additionally, for my sins, I also work with on active travel. I'm chair of the Active Travel Advisory Board for the MCA. It's in a bit of an interim period at the moment. We're just resetting that up. And I'm taking my learnings from the AWRC and the NCSM into this rather new area. So I'm an outsider.
So he's an outsider.
I'm a user.
I'm kind of an outsider as well, but I'm coming from a culture, arts and heritage background. And Steve and I have been both working with Karen Harrison, who sat behind us, and with Greg to do this work around the role of arts, health and culture in improving health outcomes for our people. So before we begin to talk about the work that we've done, I just wanted to just summarise really what culture, arts and heritage is. If you go to the South Yorkshire MCA website, there's a statement there that talks about what it is, but it also talks about how culture, arts and heritage in South Yorkshire makes a significant contribution to the local economy. It talks about 200 million GVA, and it talks about employing 6,400 people across South Yorkshire. It talks too about how the sector creates wide economic and social benefits, including supporting tourism, health, education and skills, and generating a strong sense of community and well-being. Now, I know, because I'm part of that sector, that there's some extraordinary stuff happening, that it's led by passionate, talented, motivated people who are busting a gut to have a positive impact in people's lives. What we can see, though, is that the connection between culture, arts and heritage and health and well-being is less visible. And what we tried to do through the symposium was to understand that a little bit better and to begin to showcase that and understand how we could build on it. The council, as Greg mentioned, Sheffield Museums and Sheffield Hallam University held this culture symposium at the Millennium Gallery in November. It brought together a really wide range of health and culture practitioners from the sector, but also from a lot of voluntary and community organisations, as well as the hospitals from across South Yorkshire. And all of them demonstrated an incredible breadth of high-quality activity that really is making a positive impact on improving health outcomes throughout our communities. What we saw, though, was that there was a lack of recognition, a lack of leadership, a lack of coordination, and as Helen mentioned, a lack of sustained investment. So there's some fantastic stuff happening, but often it was short-term. Overall, we could see that there's a huge opportunity to improve the health and well-being of our population if we take a more holistic, more strategic approach. Now, at this symposium, we chatted with Steve Pleasant, who I'm sure some of you will know from South Yorkshire MCA, and he said, listen guys, the ICS is being written now, there's an opportunity here, get your skates on. So that's kind of what we did. We got our skates on and we decided to do a briefing document that tried to encapsulate some of that stuff. So I'm going to hand over to Steve. There you go, Steve, to share some of that.
Thank you. Let's get my glasses in the right place. So just wanted to share what we did. There is a document, it's in your thick briefing pack. There is an online version which has got pretty pictures, which is much better to look at, I have to admit. And really what we wanted to do here is we wanted to make a statement about the worth of cultural arts and heritage to health. And the first thing we did, just as on this briefing notes, we went back to the NICE guidance just to see what it says about cultural arts and health. And there were 6 guidance links there that you can click on. And certainly the first 3 specifically mention things like singing, choirs, arts, crafts, other activities, dance. So very specifically it's mentioned in NICE guidance. So you look at, there's plenty of evidence around. Once you start looking, there's APPGs. This is a DCMS report from 2020, Days of Fancourt from UCL. And you just look at some of those bits. This bit about music therapy. I think it's well known that people with dementia are helped through music. And here's a study showing that 2/3 of people with dementia, for 2/3 of people with dementia, their agitation is reduced and medication is reduced. Another one here, if you look here, this is for community groups. So in a community setting, the arts and therapy programs, 79% of people ate better after these programs. 77% were more physically active. And this is something we see in physical activity, that you see this crossover between activities. And 80%, 82% had better well-being. So it's nailed. The evidence about arts and health and its benefits are pretty nailed on. You don't have to do that piece of research again. It's like physical activity. There's plenty of evidence about physical activity. It is good for you. The issue is, how do you actually do it? How do you do what works? So we started looking in our local region. So we had some case studies, because it was a South Yorkshire report, we did South Yorkshire. So case study 2 was the first Sheffield one. This is Mia Janssen's in and out of hospital programme funded by, I can't remember.
Doesn't matter, we'll come back.
Doesn't matter who it's funded by. It was funded by somebody. Externally, I should say, not the STH. And it was 1,500... Hospital charities, okay. And there was 800 people were supported from all sorts of groups, spinal injuries, palliative care, stroke. What you can see here, something really interesting, you've got an opera singer teaching composition, music composition to people with hearing impairments. And what you can see someone doing the sign language, and those pictures on the wall are the visual description of the music that they have composed. So what they're trying to do here is they're trying to make long-term stays within hospital more bearable, trying to improve mental health and so on. That's just one example there. You've probably heard about, you might have heard about Happy, Healthier, Healy Plus. So the Healy Plus PCN co-funded this, and this is an interesting one. The evidence in this evaluation report wasn't the best evidence. It was quite soft evidence about what happened. It was hampered by COVID. It was over the 2 years of the pandemic. But there's some key things about that, how you set up the community and how you can get the PCNs to co-fund this kind of activity. And that's something I think we could probably replicate across the city. There are other examples in there from across South Yorkshire showing things that other communities have done. And again, these things at the micro-local level, they show what can be done for very specific communities and very specific groups of people. You've got two on the top, which are Doncaster, Dance On for 60 to 85-year-old women who struggle to do physical activity. And there you've got physical activity levels going up by 82 minutes per week following that particular intervention. You've got people suffering from loneliness, that's the one on the top right, again, Doncaster Museums, inviting people to come and look at some of the exhibits and some look at those exhibits behind the scenes and looking at some of the artifacts. And again, they did Warwick Edinburgh mental health scores and found that happiness was improved, optimism was improved, and activities were improved where they're meeting new people. Bottom left was Barnsley, Kindred. Kindred was at about at-risk vulnerable families, very specific vulnerable families. They did a 2-day outdoor workshop, and you see some of the pictures, it's hilarious. You see some of the pictures that are kind of at the beginning, and you see these faces of real grumpy teenagers. And half those people said at the beginning they were happy. And I want you to look at the emoticons, because they used an emoticon evaluation scale, and just look at those. And I defy you not to read those and not cry just looking at the progression of those families. And then lastly, probably the best evaluated one was Rotherham Social Prescribing with Voluntary Action Rotherham. And they had a great group of voluntary action groups, but the best evaluated one showing that for every £1 spent, there was more than £3 return on investment. And that was a CCG project set up. So there's plenty of evidence of what things are happening within the region. There's fantastic people, and I have to say I was so impressed by the seminar. You've got some amazing people, amazing talents, but to be honest, they're broken. And that's the one thing I came away from, that some of these people are absolutely broken. I think working in the health sector is hard, working in the health and the culture sector seems to be like a double whammy to me. So there's evidence of health and wellbeing benefits. It's absolutely nailed on there. But not so much evidence locally. There's not so many good things that we can point to locally. And that's because there has been historically this lack of leadership, coordination, support of that particular sector. And as a university researcher, I would say this, there's a lack of systematic evaluation. And I want to get to the state that in 1 year, 2 years, 5 years, 10 years, where we can come back to you and do a report like MoveMore. I think that's really, really possible, where we're using the same techniques that they use. Some of the things that people say about community arts and health, about how you might evaluate, are just the same as we would do with physical activity. Right, I will stop there.
Thank you, Steve. Oh, I have to put glasses back on.
Yeah, that's good.
There you go. So, I mean, Steve has summarised what's going on. There's a huge amount going on. There's a massive opportunity for us. I think there's work to be done, and we do feel a bit beleaguered and a bit misunderstood, but I think there's an opportunity to harness all of that potential, that motivation, that huge talent that exists to make a difference and to improve the health and well-being of our population. But what we need to do before we get to that point is to take a more holistic and a more strategic approach. We need to join the dots a little bit better and connect better with you. So what do we think needs to happen? We're proposing that we set up a Sheffield Culture, Arts and Health group who will report into this group. And then they're able then to directly support the development of the integrated care strategy work plan, but also the work plan of this group as well. So we think there's a real opportunity there to harness that, but unless we coordinate and join up, things will just continue as they are now. So what might that Culture, Arts and Health group do? Well, we see this group including health and creative practitioners based in a variety of settings across Sheffield. So a bit like the group that came along to the symposium, it would be people working in hospitals, people across the voluntary and community sector, as well as the arts and health sectors. We're suggesting that this group will work to map the resources and the best practice. We know it's there. I think just getting a sense of the body of that would be really helpful. And then using that to create a strategy that develops that practice and identifies the quick wins for all of us. It'll also seek external funding to support more interventions over a sustained period of time and do the evaluation that Steve was talking about. Importantly, this Sheffield group will work with colleagues across South Yorkshire as well as part of a culture, health and wellbeing network. And the point of that is providing that leadership and that coordination across South Yorkshire and helping us to embed the impact of arts and culture and health at a local and a regional level. So what we're calling for really is your support to help us coordinate that. And really, we're asking for members to endorse that idea, so endorse the idea of developing a culture, arts and health group, thank you. But also thinking about how your respective organisations around these tables might contribute to that. How could you contribute to the setting up of an arts and health group to Sheffield, but also that networking across the region? We'd like you to support the further development of this work going forward. We'll do it. We see the need, and there's a passion and a motivation and the resource to be able to do it, but we need you to be part of that. We're asking as well that a member of this board is co-opted to join this new group, to help us shape it, to be that conduit between the new group and this board. And finally, we're asking that members of this board include culture, arts and health as part of your agenda and as part of your work plan going forward. So I know there's a lot to consider here. We've presented quite a lot in a very short period of time. There's a lot more in that report, so if you'd like to have a look at it, there's a few hard copies here. But just to come back to the primary aim of this work, it's there to encourage participation in creative activity and to support our population to be physically and mentally healthier, happier and more resilient. So we're happy to take any questions, and as I say, if you'd like to view the report, it's here on this link. It's a couple of but thank you.
Okay, thank you. Greg?
Thanks, Kim. Thanks, Steve. Great sell. Agree with all the recommendations. Not desperate for it to be me, but I suspect you may end up tapping me on the shoulder. Not that I'm not desperate. I'm not looking for more things to do. But I'm happy to volunteer. One minor point. Hate the term social prescribing. Secondly, the Sheffield scheme's way better than the Rotherham scheme. But that's just me being a bit parochial. I was struck by the sort of the parallels to the Move More thing. It won't be solved by a big strategy. It will be solved by a fair amount of work and effort over a fair long period of time. But with the sort of the getting the cultural bits, you know what I mean, the bits in the background right. So, but all up, happy to support. Think it's the meeting was a brilliant starting point. I think there's some amazing work in Sheffield which we need to capitalise on and continue to cherish.
Sounds like you've got a volunteer. Angela.
I hope we got more than one, actually. I hope there's an auction.
Thank you. And I've obviously already, thank you for inviting me those months back. I missed the symposium, but I came just after the report had been written. And I totally kind of agree that culture and heritage have a huge impact on our health. It's the words, I think lots of people perceive them like really hard, you know, like when you say culture or heritage, people think classical music, museums, and we're talking about something completely different here. and we're talking about the rich cultures in our communities and the different heritages in our communities. And that's the thing, I think we need to really represent that. Whatever we put together, it needs to be culturally appropriate. We need to celebrate the wealth of cultures and heritage in the city. Because that, you know, when people feel, valued and engaged and being able to experience their culture, I think that's invaluable. But also, you know, my family is a mixed cultures family, and I remember how important for me was to go to a music group with my baby, not knowing any nursery rhymes in English and having to learn the nursery rhymes with my children. So it goes both ways. So if that kind of cross-cultural and how an intersectionality is very important as well, because people will have different kind of mixed heritage and needs. So thank you very much for bringing this here. I'm not volunteering because I can't at the moment.
Sorry, Douglas, I missed you. Were you? Sorry, I can't hear you. Okay, sorry. Yvonne and Douglas. Who wants to go first?
I just wanted to know, because it's really important, how you're going to capture the energy of children and young people and not make it an adult kind of posh thing. How are you going to make it for children and young people who are the heartbeat and future of Sheffield?
Can I respond? Yeah. Well, I mean, a lot of the work that happens across Sheffield happens in museums and galleries, of course, but it also happens in all kinds of community settings and in hospitals. And I think between us, across the sector, we've got vast experience of working with people at the very beginning of their lives and the very end of their lives. And the work that we do is completely tailored around the needs of individuals and what works best, particularly for children and families. So I think I know you're at Children's Hospital, but if you pop across to the museum, and I know it's a cultural setting and you've got to straddle that threshold, once you get there, what you'll see and what you'll experience is great stuff that does harness that energy. But I think it's about tailoring it and making sure we're listening to what children, young people and families want to see and adjusting it accordingly. But we can do it brilliantly.
I'll just give an example. I mean, it's not my expertise. You know, you want to ask the professionals really. But so the Advanced Wellbeing Research Centre out in Attercliffe. So we've been trying to engage with the community because it's a little bit of a university thing. You know, airlifted in. So we've been working hard. And we had an open day last summer, and it was kind of a bit of a sports day. And what we did is we invited people in to have a look around, local community. If you know, you've got the 100-metre straight there, which we set up for the junior park run. So we set something up there. We had some bits of technology. We had some light gates, basically just light gates. And you run through it and see what time you get. Kids love that kind of thing. Inside, we had high jump, long jump, kick a football in a net. We had this kind of sports day type thing, and you got a badge at the end of it if you filled it all in a sticker on each one. I'll tell you what, we didn't know if anyone was going to turn up, but it was absolutely rammed. And we got quite a few local community coming to us saying, thank you for doing this. We don't usually get things like this. So that we went away going, oh my God, right. So, I've got hairs in the back of my neck already just thinking about it. So we're going to repeat that and take some of those lessons. And it was really nice that we got real engagement with local community. It was Darnell Attercliffe in this kind of university, kind of ivory tower thing. So that was just one example, and I think we want to, it's the kind of thing, sport and activity, but it's kind of a bit of culture as well.
Okay, I think it was Douglas next.
Well, I didn't need to say anything, but I mean, just to really endorse what's being proposed here. But just thinking, I mean, reflecting on what I was saying before about, that aspect of informal leisure activities as opposed to structured things, it's a great idea. And I think one thing about culture is that people don't recognise it when they're actually doing it a lot of the time. So it'd be really interesting to see that mapping. It's just a piece of work that absolutely crying out to be done. So if we can find a way of making that happen, that would be really good. Just for somebody else reflecting on a little bit of leverage we use in our ward, we funded a map that's for local people to produce in Kelham Island. That's a walking trail based on the public art there. So it just brings together all these things. More people going to there to walk, look at the art, and get that exercise. It's just got to be good all round, I think. But it's a fairly easy thing to do with the leverage of local people who are interested and a fairly small amount of money in it.
Thank you, Douglas. I think it was Helen next.
Yeah, thank you. I mean, I think it's great, and I do really sort of appreciate, you bring in that evidence. I think there's a lot of evidence, and you mentioned some of the things that we've done in Sheffield. There's an awful lot of activity which goes beyond this idea of social prescribing, which is about community wellbeing, that brings in lots of different elements of arts, culture, heritage, but is also brought together in places where people access other types of support, physical health, wellbeing support. I know Megan wants to come in, and I know that Megan can talk about that probably in a lot more detail than me, but I think what is really key is that the organisations that bring that support together for people who are furthest away from arts and culture, who don't have the agency to go into a gallery, a museum, and to access that, are organisations generally that don't get invested in to exist. They get invested in to do some of those short-term projects. The one that Healy did is, and I think that was partly funded by Arts Council, because I remember
it was Arts Council.
Yeah, I was involved in trying to make that connection in. It's a lot of work to get that small amount of money in, and they do a huge amount of activity that brings communities together that probably wouldn't necessarily go into some of the kind of more mainstream arts and culture activities. So there's something about understanding how we enable. It's not necessarily through just doing short-term things, it's about supporting the infrastructure. Great example of opening up some infrastructure spaces and bringing communities into that. Actually, if people have great spaces, then they'll get used, but we don't have that investment in the spaces, and often those spaces are in the hands of organisations that are maybe not as connected to communities, and particularly communities who are the most marginalised groups of people. So I think we need to think about that. I'm really happy to help shape some of that thinking. You've already got Greg there, so I mean, if you need more people, I can step into that. So yeah, really helpful.
Yeah,
thank you.
absolutely.
Thank you.
Thank you. I think you could tell from the interest, from the number of questions, the interest is there. I think it was Megan next, is that right?
Thanks. Yeah, I suppose it sort of follows on from what Helen was saying. As one of the social prescribing providers in the city, thanks Greg for the endorsement, but I'm not afraid to do some self-reflection actually, and think about the extent to which our social prescribers are linking people into arts-based activities. And actually, I think perhaps they're not, and I think there's perhaps a number of reasons for that. And one is about the extent to which they understand the impact and benefits to health and well-being of arts and culture. So I think there's like a piece of work there around kind of education of kind of link workers and well-being coaches, etc. around that. And I suppose the other is perhaps the extent to which they think those activities aren't necessarily for their clients, or that's not a priority for their clients that they're currently working with, because some of them are working very much on the sharp edge of that kind of inequality, poverty agenda, and that's a bigger challenge, I suppose, is that there may be some pushback that people accessing arts and culture is a kind of nice to do, but not yet, because actually I've got these really critical situations that I need to sort out first. So in terms of the work that link workers are doing, there's something to think about in that.
Yeah, thank you.
It would be great to get some link workers involved in that.
Absolutely. Interesting, just again from the webinar, just to respond to that. So at the seminar, sorry. So I chair the Parkrun Research Board. So I've been doing parkrun research for kind of like 6 or 7 years. And if you know Parkrun, it's a free weekly timed 5-kilometre run, or walk, or volunteer on a Saturday morning. And at the seminar, one of the things that someone was presenting something about arts therapy, and they said, okay, the great thing, the reason this works is because it's a free, weekly, same time, same place, non-judgmental, and all the attributes of that activity were the same as the physical activity. And again, and the analogies went further. They're not both for everybody. You know, some people like that, some people like that. So, and this one is evaluated, this one has not been. This one is promoted, this one has not been. So there's real opportunities there, and there's real just kind of analogies all over the place, just signposting the things that we can do if we all work together.
Great, thank you. I don't want to stifle the conversation, so I think I'll use the chair's prerogative and we'll just overrun a little bit. So let's take Sandy and then Lee.
Thank you, I won't be long. So thank you for the presentation, really enjoyed it. I just wanted to point out the bit of semantics that the board endorsed a South Yorkshire integrated strategy earlier, and if you're wanting to bring other partners on board, having the same strategy name is going to find that quite confusing, so it's just making sure that we, when you talk about it to somebody, that they're not confusing it with the previous one that we've endorsed.
No, absolutely, I think that's probably our mistake. So, you know, I think for us it's about arts, health, coming together through this, through the group that we've talked about, and then through the network. I think just to touch on that, though, we have been in discussion with Steve Pleasant, with Will Cleary-Gray about arts and culture in the integrated strategy as well. So that's a parallel conversation, and it's happening at that sort of South Yorkshire level. So apologies for the confusion. There's too many ICBs, ICPs,
there you go.
and
I'll take
ICSs.
it off.
There you go.
There you go. It's gone. It's gone.
But thank you.
You'll just get your head around it and they'll reorganise. So.
Yeah, absolutely. Yeah.
Lee?
Yeah, thanks very much. I just assumed that, you'd made the assumption that we just integrate it into part of the strategy, and that's fine. A really great presentation. I think, move more, violence reduction unit, yourselves, it does give us hope, doesn't it? And I was just reflecting, actually, it makes us feel better, and in a way that you can't measure, and that's exactly what you're talking about, really, isn't it? Except it does have measurable outcomes, because it was reminding me of Healthier Fleetwood. I don't know if you've come across that. It's PCN, Blackpool Way, really poor health outcomes, and have really activated their community in lots of different ways. And they've got people who've had choirs and lost a third of their body weight, people who've never been out of their house and now running table tennis clubs and in leagues and losing weight, all the rest. Their key thing was that they don't do two. They do with, and it's absolutely co-produced. And, they didn't have loads of extra money. And part of the health benefits are the self-confidence and the choices that you can make once you're involved in all this decision-making, and the community that develops out of that. So my sort of big plea would be, and I'm sure you're nodding, so you've got it already, this is absolutely not people like the university being dropped into communities. Yeah. It's working with the community, because it's their culture, absolutely. Foundry PCN is also doing a lot of this sort of stuff similar to Healy Plus. And again, just working with very diverse communities and bringing the communities together. The other flip side of that is I went to visit a PCN not far from Foundry, where there is no great sense of culture, actually. And that was one of the things from a health point of view. They sort of picked up, where are the centres where people go? People just feel lost, they feel disconnected. So, it would be great for an organisation or a group such as yourself to go where there's already stuff happening, but there's also a real need for it to go where there's nothing happening, and try and plug in and really sort of draw people out to create culture where there isn't any. So where steelworks have closed, and say, in Ballinsey where the mines have closed, there's that loss of identity, isn't it? And nothing seems to have taken its place. So, and I equally would be very happy to work with you on this as well, because I think it's just got a lot of legs. In fact, you can just put your feet up and we'll all be doing it by the sound of things, won't it? And I'm really sorry, Zach, because I feel like I've done a lot of talking and made your job of chairing really tricky.
Don't worry.
Exactly.
It's been a great conversation. Sounds like you're going to have to interview for volunteers as well, so that's quite encouraging.
I don't think we're not going to select out, so we're going to select in. There's more the merrier.
Any more comments? Or I think we should maybe move on. So just to thank you. Our Health and Wellbeing Board happy to support the recommendation. That's great. Thank you.
Thank you very much.
So, should we move on to climate change and health conference report? That's all right.
So whilst Mark and Victoria get set up, again, time-honoured tradition, this is a follow-on from the conference that we had in St Mary's in earlier, whenever it was, which was a very good conference. The reports in the pack, the conference reports in the pack, and Mark and Victoria will do the what next and the state of play.
Thank you, Greg. Many thanks for the invitation to come and speak to you today on the issue of climate change and the conference that was held back in last November, which Greg just alluded to. And obviously, it's really important for us to discuss with you how the Health and Wellbeing Board can use its leadership and influence to drive positive change on the climate agenda through all its work. I'm Mark Whitworth. I'm the Service Manager for Sustainability and Climate Change at the Council, and I'm joined with Victoria Penman, who is a Sustainability Programme Officer in the team. And as you've seen, Victoria drafted the report and was very key in actually organising the event itself back in November. Now, I'm confident that everyone in the room will be aware and have some knowledge of climate change, both the impacts, the ones that we're already experiencing, like last year's record-breaking and devastating heatwave, the predicted future impacts and risks, as well as some of the opportunities that we expect to gain from transitioning to a low-carbon future, and also adapting some of the changes that could bring. And those are frequently in the news. And as anchor organisations, many of you, including the Council, are already taking action on climate. However, as last week's IPCC report highlighted, we are now approaching irreversible levels of climate heating, and the need for greater level of action has never been more important, and that time is now. I think it's also just worth us reminding ourselves that the long-term impacts of climate change will be felt most by people who are already vulnerable to health inequalities. So an example might be that people living in poorly insulated homes may be less able to keep their homes warm during the winter, but conversely be unable to prevent those homes from overheating during the summer, during heat waves. And obviously older people who have existing health conditions are more likely to be affected negatively by extreme heat conditions, for example. Those are just two examples, and there are many more. And at last year's conference, Greg welcomed people as part of the introduction and highlighted that climate change is the biggest public health emergency that we face, intrinsically linked to the biodiversity emergency. Greg's mentioned that the report's been circulated. It has the learnings in there from last November's Climate Summit, which was held under the aegis of this board, along with the Partnership Board, with Sheffield Partnership Board, and it brought together a wide number of organisations from across the city. It was very well attended. We had over 80 attendees, and there was a good level of attendance from organisations that are represented here today, as well as many other organisations in the city. So we had representation from industry, from manufacturing, from education, from food and drinks businesses, and from other organisations representing community interests. So there was a wide range of attendees, and there was a clear message from the meeting that people wanted to see faster, deeper and more joined-up climate action from the council and across the city, and that they shared that trust, coordinated action and a shared vision was important to people. I'm not going to talk through the report itself, because as Greg said, I think the intention is to try and focus on the questions that are presented in there. But what I wanted to try and do is just focus on those key questions and the recommendations that are in there, and try and understand whether we're sort of pointing in the right direction, and whether these are the sorts of things that the Health and Wellbeing Board would be interested in progressing and supporting us on. So the main point, I think, sort of one of the questions around how the board and its constituent members and the organisations can exercise their leadership to maximise the reduction of health and wellbeing inequalities through appropriate, immediate and ongoing response to the climate emergency. And some of the measures that are suggested in here, for example, are looking at how the new health and wellbeing strategy might want to consider a response to the climate emergency. As an organisation, as a group of trusted organisations in the city, there's an opportunity there for you in terms of being able to voice an opinion on some of those very challenging issues that we need to address around climate change. And for example, one of the things that the board could do is consider how decisions and other discussions are actually looked and viewed through a climate lens. One of the things that the council's been doing over the last 12 months is introducing a climate impact assessment tool to look at its decisions. So it's again sort of seeing how that might might be something the board might want to adapt and adopt. There's obviously opportunity to invest in a resource in terms of actually how we increase capacity for local climate action, particularly when many of these actions will have wider health and wellbeing benefits. And a lot of those, I think, you will be aware of. They've been trialled in other places. Some of them are here locally, perhaps needing scaling up. But I think it's just understanding what that opportunity is. And then I think there's something around, and again, some of these actions are already taking place from conversations that we've had with colleagues of yours in your own organisations around actually how we can reduce our own emissions. You can reduce emissions through things like reducing car journeys, or things like, for example, reducing clinical waste, and some of the other things that are happening within organisations to reduce, for example, the use of anaesthetic gases that are greenhouse gases, and so on and so forth. So there's lots of things that we could be doing. There are some suggestions in here, along with recommendations in terms of endorsing the report itself, considering how we can use, or you can use your time to prepare for that transition and play an active role in tackling the climate emergency. But I'm going to stop there because I think the important thing is understanding what the options are, how we might try and explore some of these, and recognising that we don't have a huge amount of time today to address this rather significant issue. Thank you.
Okay, thank you. I was at the conference, it was really good. So, any comments, questions? Greg?
Three. I always do in threes. There is something about sector by sector holding feet to fire. We're way off track. We all know that. And we need to be accountable for that. Easier said than done, I accept. The IPPC report of last week and how well prepared we are as a UK this week was a bit bruising, to be fair. So we need to collectively hold our feet to the fire on that one. Recognise that we're probably way underinvested in the managerial efforts to get there, actually. I think, again, we've got to accept that. Personal view on this, I'm going to be pushy and provocative here. There's something about shedding light on the fundamental drivers of this, and I will name it: fossil fuel industry and big car. But we need to fess up and front up to that really, really openly. It will be difficult, it will be awkward, but I think we've got to go there. Last point from me. Just transition. We talked that, and then we should get there. And something about the green economy, we can fundamentally give people who are a long way from the labour market a leg up if we get the skills and training into the right places to grow the green economy in those bits of our labour market that are probably excluded from it at the moment. And I think we can reshape inequalities more broadly by doing that and do the right thing in climate.
Thanks, Greg. I do share a concern that it is sort of slipping down the agenda a little bit. I think we're going to have to work hard, particularly in the current climate, to actually try and push it back up there, because it just feels as if it's not the big priority that it was a little while ago. And I think a lot of that is a national political environment. So we're going to have to use our influence to try and push this as much as we can. Lee, did you want to come in?
Yeah, thank you for this. Health inequalities and climate change for me are just like, they sit next to each other. They're the sort of thing that we all know about, but it seems too difficult to do anything, and it gets ignored, and so it gets worse and worse and worse. And they're also, as you said, interlinked, aren't they? So absolutely, I think we should do whatever we can to sort of keep this right up there. It is the biggest public health emergency. You know, when we think about smoking or we think about obesity, you know, they can't be ignored, but this is more significant. Just as a sort of very personal observation, when I went on my bike to my outpatient appointment at the Northern General recently, there's nowhere to leave your bike. Do you know, there's just simple things like that that just makes it harder. You end up having to find some railings. So I think, as you know, within our sort of roles here, we've got things that we can do with our organisations to make sure that we're doing everything we can to address climate change.
Angela?
Just very quickly, because we could talk for hours on this, and the event was fantastic, so thank you very much for those who organised it. It was really well attended, and it was a very kind of positive kind of event. I think in terms of, there are two things. It's what we can do locally, and what we, you know, most of the changes need to is a proper system change at government level, really, and global level. but that doesn't mean that we cannot make the changes, especially in terms of narrative locally. Because change, as in changing the way we behave, is difficult to accept for humans. So it takes a while for people. But if the narrative is negative against the changes that need to be done, it's difficult for us politicians to make those hard decisions. And it's important that we change the perception of, if we talk about active travel and public transport, it's not because we are anti-car, but because we want to make room on the road for those people who really need to use a car, say a disabled person or someone who hasn't got any other way of getting somewhere. But at the same time, making room for cyclists and pedestrians to be safe, but also to allow buses to flow more freely. And also, like, keeping in mind that lots of people don't have cars in the city. That is just an example of one thing where it's very negative, the narrative in the city, and we need to change that narrative, because it's only by making those changes that we can then address, the health inequalities and how people don't have transport in the north of the city to go to the hospital, for example, and, to go to their surgery. So the meeting was about a lot more things, and it was all linked to culture and to food production. So it was a really kind of broad event, and it was really well attended. So thank you.
Greg?
Thanks. I agree with Angela on the narrative. I think there's something we can do there, and I agree it's definitely not anti-car, it's pro-climate, pro-health, and kind of getting that right actually shifts. And we're doing some work in that space. I think there's more to do in that space. The other thing that's maybe an ask for you two is that when the governance arrangements for this are set up, point to people that you want in places. I presume I won't escape. I'm happy to escape, but I presume I won't. Make sure that you've got the right people from the right sectors that can talk knowledgeably about what is happening in each of the various sectors, because they will have knowledge that you just won't have around what will and won't fly in sector A, B and C. So point to members of this board and others as and when you need to.
Douglas?
And just briefly, I think someone said that, climate change has almost, disappeared off the agenda. But actually, I'm not sure it has. People are still talking about climate change a lot, all the time, and throughout everything. And that's a good thing, because it shows that at least the thought of it is becoming more mainstreamed. It's not just something that's an addition. It is fundamental, and we've already touched on the climate change issues in several of the papers we've had today. But yeah, I think we just always need that prompt to make sure that it is included in things, and so we see some definite action. So yeah, really welcome the reports. Thanks for running that event, really.
Helen, did you want to?
Yeah, I guess there's so much in there, there's so much challenge around this, and we need to kind of move it into the actions. There are a number of people that are doing the thinking around this, and I've been asked to partner on the South Yorkshire Sustainability Centre work, which I don't know if you're connecting into that. The part that we're partnering on IVAS is the policy roundtables and bringing the academia and the academic work together with the policy decision making. Anything I can do to sort of make connections, if you're not already connected into that, then I'm happy to do that.
Catherine?
Again, you may be all connected in, but if not, we can make the connection. There is a Sheffield Strategic Estates group which has all the sort of facilities leads from the partnership members. Are you already linked into that? If not, we'll get you in there. Brilliant.
Fantastic. Any other comments, questions? Okay. And are we happy to support the recommendations? Brilliant. Thank you. Thank you. Let's move on. So we've got the forward plan, which I think is just for noting. Is that right?
Usual drone from me. Tell me what you want on the forward plan, otherwise it will be a forward plan according to what Greg Fell thinks. You may or may not want that to happen, but if you don't tell me, it will be what I think is important. So tell me, please.
Fantastic. Thanks, Greg. And the minutes of the previous meeting, everyone happy with the minutes? Any corrections? That's great. And then date and time of the next meeting, I assume that's a typo because it's not yesterday. So is that May? June. 29th of June. So thank you. Greg?
2 bits of AOB if I may. 3 bits of AOB if I may. I'll do them all by follow-up by email. One is a month into the clean air zone. We've got the smoothest rollout of all of the cities that have done clean air zones by all accounts. So we should formally note credit and thanks to all those who made that happen, because there was a huge managerial effort to make that happen. It's been fairly smooth, not been wholly smooth, but it's been fairly smooth, and we should never lose sight of the purpose, which is public health goal, actually. Second AOB is I'm beginning now with a number of people to write the next health and wellbeing strategy. My aim is to have it ready by the municipal year 2024, so we've got a year to write it. I'll do a brief note to board members so you can have early sight of thinking on it. I may or may not have the right ideas. You can kick it around and tell me. And the third one is I should do a follow-up again by email, but a new group has been set up to do the ensure that we've got the operational integration of all of the various bits of welcoming refugees and asylum seekers into the city, housing, safeguarding, accommodation, health and care, getting registered, vaccination, etc. The right people are involved in that, but just be aware that that is happening, and I should do your note to give you a sense of it. Sorry, fourth one, June conference, June the 14th. Conference date for diary, I don't think it's gone out yet, but we planned to do a sort of a launch event for the writing of the next health and wellbeing strategy on the 14th of June, isn't it? I don't know where yet, but look out for it. Hopefully not in the town hall, but look out for it. And we're kind of orienting it around community development for health. We're having a pretty good story in this city on that one. And we've asked a few expert speakers to give us some sort of what does state of the art look like. Some speakers from outside of Sheffield and some speakers from inside of Sheffield. And I think the challenge is for us to reflect on that and work out how we get from pretty good to awesome.
Great, thanks, Greg. I'd just like to reiterate around the ULIS zone. I think that was a brave decision, and I think it was a really welcome one. So I just want to thank everybody that was involved in doing that. Any other questions? Any other comments? So apologies for overrunning slightly, and thank you everyone, and we'll see you next time. Thank you.